that I started to talk about when we were in the posterior pharynx in the nasal cavity. And we were going to talk about some things that maybe Dr. Wolf spoke about this morning, okay? And that's the anatomy of speech and swallowing, okay? So those are the things that are associated with this pharyngeal region, whether it happens to be the hypopharynx or the larynx, or whether it happens to be the oral cavity and the oral pharynx. These are anatomical structures that play a role in both the process of mastication and swallowing, but also in the production of sounds or language in relationship to speech. Let's see if this works. So far, I'm over. Okay. All right. So we've seen this before. This is the airway, okay, and this is kind of the problem here in a human or a mammal that gets most of the time is sitting up vertically or is bipedal, and that is that this airway sits out in front of the food tube, okay? So whenever we are doing anything in relationship to speaking or swallowing, or these two tubes are going to be in relationship to one another. Now, first, if we talk about speech, it's a little bit more straightforward, believe it or not. We're talking about this upper region of this airway that's referred to as the larynx. And the larynx is made up of cartilages. And the larynx, excuse me, the role of the larynx is primarily, like we stated a few times already this year, the larynx is associated with protecting the airway. So what we call the vocal folds certainly help us to create sounds that we use in relationship to language, to speaking, words, and hopefully the people around us are understanding those words, but also from the perspective of protecting the airway. So when the vocal folds close, we can't get air from the lungs, okay, or into the lungs. So we've got kind of a dichotomous problem. If we can't breathe, we can't get air, we can't get oxygen, the organism is compromised from the standpoint of being able to survive in its environment. From the same standpoint, if we cannot breathe out because the vocal folds are closed, we cannot produce the sounds by causing the vocal folds to vibrate and therefore create language. Okay. So if we look at these cartilages here, this is the cartilages that we're associated with. Some of these cartilages are unpaired, okay, and those are the very large cartilages. And so what we see here are primarily some of these very large cartilages. Here is the thyroid cartilage, okay, this large shield-shaped cartilage, and we actually saw that in the two cadavers that we looked at in the lab the other day in relationship to how the male's thyroid cartilage is more protrusive, and that way because on average the male airway is larger than in the female of the same group. So we see that. We see that there are horns on this thyroid cartilage. Here's the superior horn and the inferior horn. Actually, the superior horn is helping to support this membrane over here that is referred to as the thyrohyoid membrane. Here's the hyoid membrane. It's kind of exaggerated in shape. I showed you in the lab the other day. Here are the greater horns, and here is the body, but you don't typically see lesser horns that are that pronounced in relationship to that. What attaches it?
Stylohyoid?
Stylohyoid, yeah. And so the stylohyoid tendon actually attaches there, and then the digastric tendon passes through. Okay, what attaches the mylohyoid? What attaches the body, the mylohyoid, okay, and what attaches to the sides, to these greater ones? It's the tongue, actually, with its lateral muscle called the hypoglossus. Okay, so those are all above the hyoid, okay. Another one of the inferior cartilages is this one that looks like a shaped structure, and this is the epiglottis, and this is a protective mechanism that can potentially help to close the airway when we are swallowing things, when the tongue is dropping back to drop the food bowl, simply oral pharynx. Okay. These inferior horns, though, on the thyroid cartilage extend over this other unpaired cartilage, and this is the cricoid cartilage. Okay. This is the cricoid cartilage, and between the cricoid and thyroid, once again, here's this thyroid membrane, which takes a position that's actually below the vocal folds. And that's significant if we had to open a, let's say, emergency airway, a temporary airway, so the person could breathe, because for whatever reason the vocal folds are in spasm or closed due to some type of upper laryngeal obstruction, and we can't breathe. But the other thing that happens here is that there is a muscle that goes alongside of this from the cricoid to the thyroid, called the thyroid muscle, and that helps to put outward tension on a membrane that's in here. That is sometimes referred to as the conus elasticus, okay? And that stretches this membrane and also stretches the vocal folds out laterally and puts tension on them, so that can change your voice. But the thyroid cartilage actually rocks backwards and forwards on that cartilage. Okay. All right, so epiglottis, thyroid cartilage, cricoid cartilage, those are unpaired cartilages. We come down here to these cartilages that are sitting on top of the back of the cricoid. Remember, cricoid is described as a signet ring. Okay, a signet ring, you know, in days of old was a ring that had a band in the underside of it, and it had a plate on the outside of it for an initial. It was an initial ring, okay? So here's the plate back here, and here's the band in front. But the arytenoid cartilages, these little pyramidal shaped cartilages, sit on top of the cricoid. And this is where all the action is, because we'll look at the vocal folds in a while, that the vocal folds are fixed to the inside of the thyroid cartilage, and they attach to this arytenoid cartilage. So there is no real movement in the front, okay? It's just a point of attachment for stretching, a point of rigidity, so that we can move these arytenoid cartilages, which are connected to the backside of the vocal folds, and either breathe or create sounds or by putting tension on the folds. So these are the arytenoid cartilages. On the top of the arytenoid cartilages sit these little crowns, so we call them corniculate cartilages. These are also paired, obviously. The other paired cartilages, one of those other paired cartilages we can see here is called the cartilaginous trapecea or trapezial cartilage over here, that helps to strengthen this thyrohyoid membrane that's sitting on top of a thyroid cartilage and below the hyoid. If we look at this from the aspect of the frontal section, so this is a frontal section or coronal section, so from side to side. Here's the thyroid cartilage once again. Here's the thyroid cartilage once again. Here is the cricoid cartilage here. Okay, we don't see the plate because the plate's been taken away, but we do see the trachea down here below the cricoid cartilage. Okay, where the air tube extending down to the lungs. On each side of and below the cricoid cartilage are these two structures. These are the thyroid glands. So the thyroid gland, although the thyroid cartilage is up here, the thyroid glands are actually well below the thyroid cartilage and over here below the cricoid cartilage. So here we see, this is the epiglottis once again. We'll see another view. There's the third paired cartilage. We'll see in here in a fold called the areoglottic fold. But this area up here is the vestibule of the larynx here. So sometimes these are called vestibular folds over here. Some other people may call them ventricular folds. But these are the folds that are created by bulges in a muscle called the thyroarytenoid, okay? Its upper extent, okay? We see down here that there is muscle in this fold here below it, and this fold below it is created by a inner border of a thyroid muscle called the vocalis muscle, and that is basically the vocal folds in here, okay? There's a membrane that is basically the mucosa that creates almost a string-like relationship on the borders of the vocalis muscle in here, and that's what vibrates, that's what we can manipulate the sound created by that vibration, okay? And then in between here, this space between these vestibular folds and these true vocal folds here, or the vocalis muscle, this is many times called the laryngeal sinus or the ventricle, okay? And so, just in lay terms, these are folds that are referred to as being false vocal folds. They really have nothing much to do with the process of creating sounds or speech, but these vocalis muscle covered mucosal surfaces, these are the true vocal folds in here, okay? And then here is the cricoid cartilage, here's the thyroid cartilage, the cricothyroid membrane would be right here, so that is in a position that is below the vocal fold. So that's why we can create a temporary airway during an emergency situation. We can't do it up here, okay? We can't do it up here because the problem is typically related to the vocal folds being in spasm and closed shut, okay? Here's the tongue up here. This is the root of the tongue. Up in here, here we can see this, this border here. Sometimes there's a little foramen here called a foramen cecum of the tongue. Dr. Frideau or Dr. Wolf talk about what arises from the foramen cecum is the thyroid, or portions of the thyroid gland, parathyroids. These little papilla up here, these are Vallee papilla. These structures here that kind of look like these, but in miniature, these are actually lymph tissue. This is actually lingual tonsils sitting down. If we look at some of the muscle attachments and this third cartilage, okay, here's the epiglottis over here covered by mucosa. Here, once again, is the vestibular fold or the false vocal fold. Here is the true vocal fold that is associated with the vocalis muscle. The arytenoid cartilage is sitting over here on top of the cricoid, okay, and we see some of the muscles associated going between the two arytenoid cartilages. They are either transverse or they are oblique. So we have this muscle here in relationship to this structure. Here's the border of the epiglottis. If we look at over here in particular, kind of showing it on the other side, over here we see that as we come down the border of the epiglottis, here's the corniculate cartilage sitting on top of the arytenoid cartilage here, okay? But this cartilage in here is sitting in the membrane of the epiglottis in this fold that comes down along the borders of the epiglottis to each side of the arytenoid cartilage. So to the left arytenoid cartilage, to the right arytenoid cartilage. And that's called the aryepiglottic fold, okay? So this cartilage, the cuneiform cartilage, sits in there and helps to create some strength in that membrane as this aryepiglottic fold or this mucosa is attaching to the top of the arytenoid cartilage or the cornicula. Okay. So we see that here. These muscles here are probably two of the most significant. This one over here is the lateral cricoarytenoid. This one over here is more posterior cricoarytenoid. Here we see some of the other muscles in here in relationship to aryepiglottic muscle over here, and the cuneiform cartilage over here. We're seeing here in that window. And we're seeing some of these other like thyroarytenoid muscles and aryepiglottic muscles in here. Okay? Now, one of the things about this is that the primary thing is to be able to protect the airway. So there's only one muscle out of all of the muscles associated with the laryngeal apparatus that can directly open the vocal folds or pull them apart. And that's called the posterior cricoarytenoid. It is an abductor of the vocal folds. All of the other muscles in here do something to close the vocal folds or to adduct them, to bring them together, okay? The only muscle that doesn't do that is the posterior cricoarytenoid. You'll actually be able to see that. That's one muscle that's fairly obvious in the cadaver. But here we can look at them here and look at some of these muscles in relationship to the arytenoid cartilages. So here's the arytenoid cartilage sitting on the back of the cricoid. This is a muscular process out here. So muscles such as the lateral cricoarytenoid and the posterior cricoarytenoid attached to that. This process here that's more forward, that's the vocal process. The only thing that really attaches to that is this really inner border of the thyroarytenoid muscle that is helping to create tension on this mucosal membrane that we call the vocal cords. So that's sitting over here. Now, here, the cornicular cartilages are, in this image is left on by the illustrator, but here if we look behind, we see that there are muscles that go from one arytenoid cartilage, its vertical process, to the other, and those are called transverse arytenoid muscles. And then we have these muscles here that cross obliquely across the back of the laryngeal apparatus, and these are actually a continuation of the area of the glottic fold as it meets the arytenoid cartilages. Okay, so that's those oblique arytenoids. So these are all, if you look at them, you could see that when muscles contract, they shorten, right? Okay? To move things, we have to contract muscles, okay? To go, leave that contraction, we have to go to some other muscle group that does the opposite movement. For example, the biceps muscle helps to flex not only your arm but your forearm, but the triceps muscle does the opposite. It's the antagonist of the biceps, and it helps to extend. It helps to extend your forearm. We look down on this apparatus, we see more of this musculature. Okay, once again, here is this muscular process of the arytenoid cartilage. Here is the posterior cricoarytenoid coming from the back of the cricoid cartilage and attaching to this muscular process of the arytenoid cartilage. Here, from a more lateral perspective, we've got this muscle here that is called the lateral cricoarytenoid muscle, and then that is coming from the lateral border, the superior lateral border of the cricoid cartilage and attaching to the muscular process. This is an adductor, this is an abductor. These little muscles from the cricoid cartilage to the thyroid cartilage, this is the cricothyroid muscle, and there's one on each side, and what they do is when they contract, they pull outward on the wings, on the lateral wings of the thyroid cartilage, and create tension on the vocal folds. So that's something that can raise, increase the frequency of sound or create tension on the vocal folds. All right, so here is the cornicular cartilages up here. Here's the arytenoid cartilages back here. Here's the vocalis muscle, this inner portion of the thyroarytenoid muscle over here. And here are the transverse and oblique arytenoids back here in relationship to that. Here's the posterior cricoarytenoid and a portion of the lateral cricoarytenoid over here. This is this continuation really of the cricothyroid membrane is many times referred to by authors as the conus elasticus in here. Here is the vocal ligament or the vocal membrane. So this conus elasticus will actually create this kind of submerged membrane that helps to provide some structural support for the vocal folds themselves. And then here we have the cricothyroid muscles, which are coming in here to attach to the thyroid cartilage from the cricoid cartilage. Okay. So here's a cadaveric demonstration of this area. It's a little grainy. I couldn't find worked all morning on revising these lines. But for some other reason, we can't really see that, but this is the back of the cricoid cartilage. This is posterior, this is really more of a lateral view. So here is the posterior cricoarytenoid. Here the arytenoid cartilages are over here and over here. Here's the transverse arytenoid, here are the oblique arytenoids here. Here's this airy epiglottic fold with the cuneiform cartilage over here. You can see a little bit better, this number 6, and then the corticular cartilage sitting on top of the arytenoid cartilage. Here's the epiglottis over here. Yeah, let's see, what else can we see? That's about it. Here in a lateral view, we see the false vocal folds, the vestibular folds, and the true vocal folds, the ventricular folds. Okay, so this is a nerve that we've seen more than once. The first time we saw it, we were in the thorax. Okay, and this nerve is a branch of the vagus nerve. And this is what we refer to as the recurrent branch or the recurrent laryngeal branch of the vagus nerve. So if you remember, it's a little bit easily, more readily seen on the left side because it loops under the aorta. Okay, it's a little bit harder to see on the right side because it loops under where the brachiocephalic artery is giving off the subclavian vein. Some people say it loops under the brachiocephalic. Some people say it loops under the subclavian artery. So on the right side, it's a little bit higher up, but they're pretty much the same size in terms of their density. So this is running up between the anterior wall of the esophagus, okay, and the posterior wall of the trachea, okay. Now, when it comes up, and we'll see this in the lab, okay. Just remember when you're studying for the practical, there's nothing I can't show you, okay? So don't make the assumption that things are too small, okay? So this is one of them, okay? We can see this nerve, this recurrent laryngeal nerve, as it comes up and comes into this, let's see, as it comes up here and comes in through the lateral borders of the posterior cricoarytenoid and the thyroarytenoid muscle. So it comes in behind the cricoid cartilage and the thyroid cartilage from in the back. Here's the front of the thyroid, here's the front of the cricoid. So that comes in here and tucks in. This nerve is the only innervation of any one of the intrinsic muscles of larynx, okay? And I say intrinsic because this muscle out here, this cricothyroid muscle, is not intrinsic, it's outside, okay? But all of the muscles that are inside associated with an attachment to the arytenoid cartilage are intrinsic muscles of the larynx, okay? Now, so, did Dr. Wolf talk about today what innervates this? Cricothyroid. What? The internal laryngeal portion of the superior laryngeal nerve. Okay? Okay. The internal laryngeal comes off a branch called the superior laryngeal nerve. If you, next time we go to the lab, when we start looking at this, I'll show you this. The internal laryngeal comes off of the superior laryngeal, goes through the thyrohyoid membrane and into the hypopharynx, okay? But it also, there is a superior portion of the superior laryngeal, or this internal laryngeal branch, that goes up where? Where does it go? Where does the superior portion of this internal laryngeal go? Okay. What's this large structure that we move around in our mouth to speak, to articulate sounds? goes to the root of the tongue. Okay? Remember, in relationship to innervation of the tongue, the anterior 2/3 are of the dorsum of the tongue, the sensory surface of the tongue, are innervated by what? The sensory surface, the dorsum, is innervated by what? Okay, that's trigeminal for general sensation, but what's the lingual branch of the trigeminal carrying back to the facial nerve? What is that branch? Or the tympanic branch of the facial nerve? What type of sensation is that bringing back? Possibly some GVE, but mostly taste sensation from the dorsum of the tongue. As we get down into the mucosa, yes, GVE. Okay? So those are coming in relationship to the chordotympanic branch of 7, which is riding on the lingual branch of 5. Okay? It's kind of almost the same relationship we had with the greater petrosal, but it's not as diffuse. All right, what about the posterior 1/3 that sits between the tonsils? Glossopharyngeal, okay? So that surface in there, that mucosal surface in there, is innervated by cranial nerve number 9, in particular fibers that are associated with general sensation and taste sensation, and also, it's believed, general visceral efferent, or parasympathetic sensation. Okay? Okay. So that's the anterior 2/3 and the posterior 1/3. Now we have this area between the epiglottis and the posterior extent of the tongue. It's referred to as the root of the tongue. This is where this internal laryngeal branch of the vagus nerve comes in and receives general sensation, and also it receives a special sensation for taste. There are actually taste buds on the front of the mucosa of the epiglottis. But also there are probably fibers that are motor for GVE type activity or secretomotor sensation, secretomotor activity of those mucosal cells on the posterior-most aspect of the tongue and over the tongue. So we have essentially 4 cranial nerves that has some relationship to the sensation associated with the tongue. Okay, and 3 of them also have a relationship to GVE or secretomotor activity associated with mucosal glands. Why is that important? Why is that important? I don't know if Dr. will talk about this. We'll talk about it more in neuro. But what are taste buds? What kind of a receptor are they? Are they like,
GSA?
They're chemoreceptors. Taste sensation is receptors for the sense of smell, are chemoreceptors. What does that mean from the standpoint of how they function? In order to detect an odorant or a tastant, that odorant or tastant has to be dissolved in fluid. In the nose, it's mucus, okay? In the mouth, it's saliva. Okay? Individuals that have a dry mouth, for whatever reason, typically complain about altered taste sensation. Altered taste sensation. Okay, so they're chemoreceptors. Okay, this is just a kind of a quick chart talking about where all of these muscles come from and go to from the standpoint of origin and surgeon. The muscle that I'm most concerned that you learn about is the one that only does this, posterior cricoarytenoid, because we can see it easily in the lab. And so this attaches to the muscular process of the arytenoid from the cricoid surface, or posterior cricoid surface, and this is the only muscle that abducts the vocal folds. Okay, that's important if you want to breathe. Okay. Okay, so what is speech? Speech is the process of expressing language. It's communicating with others in your group, okay? If you're a dog or a cat, you know, lion, tiger, or bear, they have their own sounds that they make to communicate with each other or with other organisms in their environment. Us, we use words, okay? And other animals probably think we're kind of silly too, the way we speak. But the central nervous system provides us with both a mechanism to create and express words, as also to understand the words we want to say. We'll talk about this more in neuro, because there's actually a speech center in the cerebral cortex that was described by a neuroscientist named Broca, and there was a center, a language center in the posterior temporal area referred to as Wernicke's area, which allowed us to assemble words to speak them intelligibly, or sentences. Okay? When those two, when something happens to either one of those centers, it disturbs our ability to speak clearly, or speak understandably. Okay, so the anatomical structures which allow us to pronounce these words are the lungs. That's really, we see, that's the power source. The lungs have to blow air across the vocal folds, or the vocal membrane. And, you know, so in many ways, it's kind of like a, I guess you would consider it somewhere between a string instrument or a wind instrument. You know, the wind instruments typically have some kind of a very finite reed that we cause to vibrate to make sound. But also string instruments, you know, have this, have these tense membranes that act as strings as we blow air across them from the lungs. Okay? Now, we've got the larynx with its vocal folds and chambers, okay? And that kind of creates a little bit of a space where we can have an effect on the tonal quality of the sounds that we make, okay? The tonal quality of the sounds we make. For example, you know, when we go through, when we have this life-changing process where we're going through puberty, in particular in relationship to a little bit more testosterone going to skeletal muscle, what happens to the muscle? What? It grows, it gets thicker, okay? Some of these muscles are underneath these mucosal surfaces in the larynx. So what typically happens to, more so in the male than in female, but it can happen in either. What happens to the male voice is goes from, let's say, 10 years old to 13. Deepens its voice, because now a lot of the absorption of the sound or the tonal quality has changed because of the thickening of the muscles and the thickening of the membrane inside the hypopharynx. Then we've got the oral and nasal cavities, and the oral nasal cavities, we'll see, those also have an effect, okay, because on their size, okay, on the shape of the dental arches. You know, displacement of teeth changes the contour on the inner aspect of the oral cavity in relationship to how these words we're going to speak, you know, sound, okay? Or missing teeth, okay? You know, or diastemas, okay, between teeth. Anything that happens there can affect how the sound is going to be heard, okay? And then the tongue and the dentition, that's where we use this tongue to basically articulate these sounds, really make finite sounds. You haven't had removable prosthodontics, and I don't know who Dr. Love is. Is Dr. Love, as far as you know, going to be teaching you? He's excellent. Yeah. Okay, so when we're placing a prosthesis, or even you know, removable prosthesis, or even fixed prostheses, we want to be sure when we do our try-ins that we haven't changed the way that the patient sounds when they speak. You know, so for example, we can create a lisp, and that the patient didn't have before. And the patient will tell you, well, you know, since we did this procedure, doctor, I'm always, you know, I'm always lisping, you know. So that just cost you another month of care, because you're going to have to do the prosthesis over, okay, in order to eliminate that. But there are periods where you can check this in your, you know, in your try-in phases and things like that, that you can see that you're not changing the way that they sound. Or, you know, even greater, anybody who plays any kind of a wind instrument, trumpet, clarinet, saxophone, or something like that, if you change the position of their teeth, you can change their ability to play the instrument the way they did before they came to see you. Okay. So that's a lot to look at, I know, but you volunteered. Well, you didn't volunteer. You decided this would be a great profession for you. You know, it looks great, looks easy, but it's not. But it can be fun. All right, so the power source in speech is the lungs, the control of flow that is causing the vocal folds or the vocal membrane to vibrate. The sound source is the vocal membrane. It's basically a string instrument. We vary the tension so we can vary the pitch. Okay? Then we have these spaces in here that are in the hypopharynx, the oral pharynx, the nasal pharynx, that are resonators. They can change the way that the sound waves bounce off of or are absorbed in this area and create a tonal quality to your communication or to your speech. So we can vary tones, we can vary the color of sound. I mean, if you're any of you in choirs, were you're singers? Or do you sing in the shower in the morning? I don't know. But I mean, if you'll notice, just being in the shower, things sound good. But we can vary tones. Have you ever I mean, I'm sure that at one time you've gone to a zoo, and have you ever, as you're walking through the zoo, you might hear the sounds being made by a monkey called a howler monkey. And a howler monkey is interesting because its hyoid bone and its thyroid cartilage are actually one continuous cartilage. It's like a deep canyon. So they can echo their sounds that they send through this canyon and out their mouth, and you can hear it for miles. Okay, so whether it happens to be in the zoo or it happens to be out in the jungle, they can signal by communicative mechanisms their groups throughout this huge environment. Okay, just by changing the way that the sound leaves their hypopharynx. Like, I mean, you know, have you ever been in a canyon and just shouted out, and because the canyon walls are so high, the sound as it's going is actually bouncing off the walls of the canyon and reverberating over and over and over again until the sound waves dissipate? Okay, echoing. Okay, then we have the articulators for speech. That is the tongue and the lips and the cheeks. Okay, that's the tongue and the lips and the cheeks. Okay, so anything in there. I mean, you are working in this area with patients all the time. Okay, this is something you have to be cognizant of. If you do anything to the dentition that changes its position within the confines of that patient's oral cavity, if they have done anything in there to their dentition that changes the position of the oral cavity, for example, have lost teeth or things like that, or they have things like diastematic spaces between their maxillary central incisors or things like that, that's going to affect the way that speech is articulated. Also the nasal cavity, because as we are blowing air across the vocal folds, it's extending. The sounds made by it are going into the oral cavity and we're articulating it, but there's still waste air that will go up into your nasal cavity, okay, and will leave through your nose, you know, in a very slow fashion. However, for individuals, for example, you have deviated nasal septums or some type of inflammatory process in your nasal mucosa, all of a sudden the character of your voice or the color of your voice changes. The sound waves become obtunded because the air can't get out as fast. Okay. So all of this relates to what's happening within the confines of these cavities in regards to this thing we don't really think about all the time, which is speech. But working on patients, doing things in their oral cavity, you've got to think about it. Okay. because if something happens and it didn't go the right way, your patients will definitely let you know, okay? So, let's see. Okay, so let's take a 5-minute break and we'll talk about swallowing. We're in a position in this oral cavity where patients come in with all kinds of problems, okay? It could be missing teeth, it could be their teeth hurt them, it could be broken teeth, it could be that they have periodontal disease or whatever. But whatever affects the teeth affects their ability to chew properly, okay? If they have malocclusions, that affects the way their teeth are in relationship to chewing or mastication, okay? Now, our tooth and jaw position changes from birth into childhood into adulthood, okay? So we actually have two defined types of mandibular maxillary relationships in the infant, okay? It's not impossible for a neonate to have a tooth, but it probably is what we would call a natal tooth or a neonatal tooth. It's something extra that got in there for whatever reason. And in all honesty, you may, or at least the pediatric dentist will be called upon to take that out because it's irritating the infant, okay? But they don't have teeth, okay? They don't have teeth. When do they have teeth? You know, according to the tooth chart, anywhere between, between what, six months and who knows, okay? And that's what upsets parents. They said, Johnny has not gotten his any teeth yet. What should I do? And if you've taken radiographs and you see that the teeth buds are there, you say, be patient and wait. Parents aren't patient, okay? Especially with their children. So for whatever reason, it's either the child's attitude or the people taking care of it. So the mandible does not have an L shape at this point in time. It's really a straight bony bar. We'll look at it in the deciduous skull. But it's a straight bony bar. So if you drew a line through the middle of the condylar pole and extended it to the menton, the chin, it would be just straight, okay? So they don't have teeth, okay? The mandible's a straight bony bar, okay? How are they getting food mostly? How is their food through sucking, right? Okay? So you don't really need teeth at that point in time because their diets are pretty much liquid or soft, okay? As they start to get teeth in, that's going to change things in relationship to the oral cavity. Which teeth do we get first? Do we get posterior teeth or do we get anterior teeth? Anterior teeth, okay? Okay, so it's interesting, as teeth erupt, we are actually creating somewhat of an anterior-posterior tripod, okay? Where the anterior teeth, as they erupt and are coming together, are now holding the space in the front for those posterior teeth to come in, okay? So that happens in the deciduous dentition. It also happens in the adult dentition. It's more significant in the adult dentition, obviously, because these are going to be the last set of teeth that they have. Okay? Because we're not rabbits, we're not sharks, so we've got basically a deciduous dentition and we have an adult dentition. Okay, so primarily they are sucking. Okay, so what's the musculature that we're going to use for this process of sucking? Well, we still have to close our lips together, even though we don't have teeth that really give us the support we need to swallow. But to suck this liquid in, we have to form a seal around the nipple, whether it's the mother's breast or whether it's some artificial device associated with a bottle, and they're sucking this in. So primarily we're dealing with muscles of facial expression around the oral cavity, and this is probably the primary role, not to make a facial expression, but to basically control the opening they surround, like orbicular, orisodis, and so forth. And also the tongue. the position of the tongue. The tongue position of the tongue is very, very important. The tongue actually is a rather, in the adult anyway, but also in the neonate, is a really strong muscle. Is a really strong muscle. But, all right, so around 18 months or older, we're getting close to having a some kind of a dentition in there. Okay, so this is relationship to the mature swallow. So now we've got teeth. Okay, once again, what are the first permanent teeth to come into the oral cavity? Okay, mandibular, and then maxillary anteriors and so forth. Okay, so if they're coming in like this, and you have this, minimum amount of what we call overbite, vertical overbite and anterior, posterior overbite, or overjet, okay? And they're like this, they're gonna hold there while the permanent teeth come in, while the molars come in. Now, what if that child has what we call a protrusion of their upper anterior teeth for one reason or another? What's this movement here, the dentition, gonna cause in the back? Are the gum pads going to be closer together? Maxillary and mandibular, are they going to be farther apart? They'll be closer together. Okay. So not only, we'll talk about this as we go on, not only do these individuals have this kind of bimaxillary protrusion, what do we mean by that? It means that the upper teeth are pushing out on the upper lip, the lower teeth are pushing, anteriors are pushing out on the lower lip. Okay? And by coming like this area in the back is now closer together. So what do you think that would cause in this patient that was just going to, it's not going to compensate for anything, but it's going to grow into that position because of what happened developmentally, okay? So the molars and premolars aren't going to erupt as much. So they're going to be intruded, either in the maxilla or in the mandible. So, there is something to be said for development. It doesn't all fall into the realm of pediatric care or orthodontic care. It's something that you may be the first person to notice in this child. And talk to your colleagues about referring this patient because you're starting to see this now. Some of it is developmental. Some of it's developmental because there are cultural differences in the shape of our heads, okay? The shape of our faces. Okay. There are round heads, there are thin heads. The Dr. Hans talking about dolichocephalics and brachycephalics. Okay, so who's the round head? Brachycephalic. Okay. And the dolichocephalic is the narrow head. Okay. All right. So the mandible starts to grow. The ramus starts to grow more vertical, so we get more of an L-shaped mandible. Now, it's harder now with an L-shaped mandible to suck on things for a couple reasons. One, there's dentition, okay? And the dentition kind of gets in the way of closing your lips around the nipple, okay? There are groups, though, that will breastfeed their children well up into their early childhood years, okay? One of the groups is called the white sheep. So I give them all the best because I could see that being possibly a very painful process for a child that has them. All right, so, but they have dentition. Now, when they close together, the teeth are together, okay? The teeth are together. They are now eating a mixed diet. That diet, there's liquid in the diet, but there are now solid foods in the diet or semi-solid foods in the diet. That now, with the teeth they have, they either have to, basically pull it apart or start to chew it, start to masticate it, okay? So then they have to swallow it. And to swallow it, they have to have stabilization in the front. Just as the neonate has to be able to create a seal in the front, the older child and the adult has to also be able to create this seal in the front by closing their teeth together and allowing their lips to come together so that the food, when they swallow it, doesn't get pushed out. Okay. So musculature changes a little bit here. So now we are dealing with muscles of mastication, because we're doing more chewing prior to swallowing the bolus of food we're forming. And also the tongue, once again. The tongue is probably one of the most significant structures because the tongue actually moves the food around in your mouth as you bring it into the mouth and forms it into what we consider a swallowable morsel, okay? Swallowable morsel. Okay. So here is the deciduous mandible. There's no teeth here, but there are tooth buds. And here from the condyle to the menton, you see that this is basically a straight bony bar, okay? Why is this so much larger than this? What's happening in here that's not happening here? What's up here? The brain, okay? Brain is probably the largest thing in a neonate, in a newborn. This is, okay, so this is all, that's their neurocranium, and this is their visceral cranium down here, okay? With the airway and with the maxilla and the mandible, here you see the mandibular tooth buds, and here for the deciduous definition, okay? So this is a neonate, this is a newborn, okay? And they primarily have this straight mandible that is used for sucking. There's no dentition and so forth. Then we go here, and here we've got an adult we've got a third molar. So what would you think that the approximate age of this individual from the youngest extent has to be? He's got erupted third molars, okay? Completely erupted molar dentition, completely erupted teeth. So when did third molars stop erupting typically? Or in the early 20s, right? 21, 22, okay, if they erupt at all. So in this individual here, we've got an L-shaped mandible. We have a dentition present. It's got a nice, nice orthodontic result. I don't know if this skull ever had orthodontics, but at least when the teeth were replaced in the jaws, he did. So here's a little bit of, maybe a 1.5 millimeter overbite and an overjet. So now when this individual has this skull and this dentition swallows, he's got to put his teeth together to swallow, to stabilize the tongue in particular, and the airway and the food tube. Okay, so we looked at these guys before, all right? Here is this infrahyoid group of muscles. Here is the suprahyoid. Here we actually saw some of these in the lab the other day. Here's the mylohyoid. Here, this is the mylohyoid A joining left and right. And here's the anterior belly of the digastric. Okay, here's the hyoid bone. Here's this lesser horn sticking out. Here's the stylohyoid muscle coming down here, and the digastric muscle coming up just underneath it, okay, and coming through that sling from back here and upward, okay? But then everything below the hyoid bone is what we refer to as an infrahyoid muscle. The sternocleidomastoids have been cut away in this particular illustration. Here, over here, this is a muscle coming up from the sternum to the hyoid bone, or sternohyoid. Underneath it, there is a muscle that is coming from the sternum to the thyroid cartilage over here, and that's the thyrohyoid. And then it has a union, it has a Raphe type union, or intermuscular union with this muscle. This is the thyrohyoid, and that attaches from the thyroid cartilage up to the hyoid bone. And then we have this muscle here that is coming from the shoulder and coming up to attach to this corner of the hyoid bone, approximately between this greater horn and the lesser horn. Okay, this is the omohyoid. Okay, so what's the significance of this? Well, one of the muscles here we can't see is attached to the inside of the mandible. That's called the geniohyoid. There's these two little bumps. I facetiously call them the happy bumps because they're called the genial tubercles. Okay, so one of the bumps is higher. Dr. Wolf talked to you yesterday about the genioglossus and the geniohyoid. Okay, so genioglossus, the tongue attaches to the mandible, right? Okay, geniohyoid, the hyoid bone attaches to the mandible, okay? Actually just deep to the monohyoid, okay, which is basically the floor of the oral cavity, floor of the mouth. All right, so we have to somehow, here, they're all connected to the hyoid bone or the thyroid cartilage that is associated with our airway over here, or they're attached to our mandible. Okay. So when the mandible closes and articulates with the maxillary dentition, what is it going to do to the hyoid bone? Where is it going to pull it? Up and forward, okay? And up and forward, okay? And it's going to be balanced by muscles that are providing some posterior lateral force. Here the stylohyoid and the digastric posterior belly. And then inferiorly, we've got the sternohyoid, sternothyroid, thyrohyoid muscles here that are alongside the lateral and the anterior aspect of the thyroid cartilage and the hyoid bone. And then we have this this posterior lateral inferior extension of the omohyoid. So we're pulling this upward, and anterior. What's behind it? What's behind this? The esophagus, okay? So just that movement alone provides a little bit more space. So now when the tongue kind of rolls the food back off its surface into the oral pharynx, it has a little bit more room to move this food into the esophagus and not the airway. Unless, all of a sudden, you decide to breathe while you're swallowing, or you decide to speak when you're swallowing, okay? We've talked about this. It's called, you can get that food bouncing off the side of the esophagus and into the larynx, okay? And that's going to set up should set up an extreme amount of coughing, but if it hits the vocal folds, they slam shut, okay? They slam shut, and we've got a blocked airway. And Heimlich said, I'm going to show you how to deal with this. He said, you're going to get behind the individual, you're going to wrap your hands around the lower portion of their belly, and you're going to squeeze as hard as you can, and hopefully the food will be forced out by forcing the liver and the stomach into the diaphragm, and the diaphragm creating this excessive expiration, okay? Or you're going to stop breathing. So there's terminology that's used for this, you know, because it happens a lot. You know, power breakfasts, power lunches, power dinners, whatever, when you're doing all the discussion at the same time you're eating. It's called a café coronary, okay? Café coronary. So these infra and suprahyoid muscles are helping to move the airway out of the way of the esophagus during the process of swallowing. And here are just the muscles once again. So here's the omohyoid coming over here. Here it is over here, underneath the sternocleidomastoid muscle as it's running from the shoulder over here. This is the area we looked at the other day. Here's the carotid sheath structure, the internal jugular. Here's the anterior scalene. Here are the brachial plexus nerves and so forth. Okay. Here's the thyroid gland tucked under here. Here is the thyroid cartilage up here. The cricoid would be down here. Cricothyroid membrane would be right here, okay? Remember, you can feel that. You can not only feel that in yourself, you can feel that in someone who happens to be passed out because they're not breathing. So here is a sternohyoid muscle over here. Here is a sternohyoid that has actually been cut. And here we have mostly sternothyroid coming up here, okay? You can't quite see the raphe as well, but it's basically right here, and this is the thyrohyoid going up to the hyoid. Okay. So these are the infrahyoid muscles, okay? They're providing this anterior, inferior, post-lateral stabilization of the airway, okay, as we bring our teeth in. Okay, so where are we swallowing to? Okay, well, here is the airway. And back here, this is the esophagus, this is the food tube. So right against each other, we see the epiglottis. We see the epiglottis sticking up here over the top of the airway over here, or the glottal opening, or the glottis. Here's the tongue. Okay. We look at the tongue. You can see this here. You can see this discrepancy between this here and this here. That is all sensory surface. That's the dorsum of the tongue. So anterior 2/3. Okay. Posterior 1/3, and the root of the tongue. Here is our geniohyoid muscle underneath the genioglossus. Here's the hyoid bone over here. Here's the lower genial tubercle over here. And then under here we have attaching from the anterior lateral side of the mandible, we have the mylohyoid coming here to the front of the hyoid bone. So that's what we're seeing in this particular shot. Here is the posterior pharyngeal muscles, superior pharyngeal constrictor, middle pharyngeal constrictor, inferior pharyngeal constrictor down here, covered with mucosa. Here on the back of them, we'll talk about this, I guess, today rather than on Friday. On the back of this muscle is fascia, is deep fascia, and that will be considered be creating a wall or a potential space between the vertebrae and the posterior pharyngeal wall. Okay. So here's the oral pharynx, here's the nasal pharynx, here's the soft palate hanging down here. Okay. The act of swallowing is going to create what we call a peristaltic wave that's actually going to start up here, and the soft palate is then going to come a little ways back as it starts to rise, but as this muscle starts to contract, it will create a bulge here. We'll talk about that because there's kind of an urban legend about what that's called. But then the food bolus will be basically the tongue will come down and slide the food bolus, not usually over the top of the epiglottis, but alongside it, okay, along either side of it. We looked at this the other day here, looking at it from behind. These are the muscles, okay? Now, we talked about that a little bit, okay? Once you get into the esophagus, what's the difference between the esophagus, the middle to lower esophagus, like down here, and further down into the digestive tract, than here? What's
Relative
the
composition of smooth skeletal muscle.
Well, that for sure. This is all skeletal. Okay, this is all skeletal. The upper portion of the esophagus is skeletal. Okay, what does that give you the opportunity to do? Gives you an opportunity to stop the swallow, to literally push the food back up. Okay, once it's down here, that's where it is. Okay, whether it happens to be food or the crown that you were hoping to place and get out of here, or an endodontic file, or some large composite restoration that you happen to drop into their oral cavity. Remember, we have a tendency to work for patients mostly in a supine position, okay? Lying flat. Okay, and they're teaching you how to use rubber dams. I would say that maybe 2 out of 10 dentists use a rubber dam in their practice. They're depending upon their dental assistant with that aspirating tip to catch anything that bounces off that tooth or bounces back. But here, you typically, what do you get, a dental assistant? Let's see, we got one. For sure, we got one once in our junior year and once in our senior year. We got to use the demo system. I don't know if they've improved upon that, we've talked about that. It would make sense, it would save you a lot of time, but we'll see. We'll see as we move into this progressive environment we're moving into, how well that goes. All right, so here's the superior pharyngeal constrictor. Remember, it extends from the side here, actually the medial pterygoid plate. It's out to the side, and also to the midline of the occipital bone, this little bump called a pharyngeal tubercle. But it doesn't go all the way up to the base of the occipital bone. There's actually a pharyngobasilar fascia. This is just a fascia sheath. This is important. I don't know if Dr. Stoyanov, you did oral cancer, didn't you? You've done that already. Did he? I thought they were doing that. Maybe it was just with the second years. Okay, so you haven't had oral cancer.
Oh, yeah, many times. We covered it, and then it seems like we had someone else, immunology, cover it last week. Let's see, the guy who does the point neck exam, covered oral cancer, we're pretty much covered all of that.
Okay, so did any of them talk about a cranial base tumor?
It's a good likelihood. Don't recall.
Might have been referred to,
Right.
but you might have been dozing, you know, just one of those things. All right, so what's sitting on the inside here? I'll be talking about this in a very second set of lectures. What's sitting on the inside here? This would be, what's in front of this? What space is in front of this?
Also pharyngeal.
Inside, in front of this muscle. What's in front of this muscle? What space? Has something to do with the nose.
Nasal pharynx.
Like nasal pharynx, okay? And we will be talking about it definitely from 3 to 5. What is sitting on the inside of this mucosal tissue? There is a lymphoid entity referred to as an adenoid tissue or a pharyngeal tonsil. Okay? Sometimes pharyngeal tonsil is due to chronic irritation, like chronic rhinitis, chronic pharyngitis, can become dysplastic. They can break through this membrane here and go along the base of the skull. Okay. What's coming out through the base of the skull? Bunch of things, right?
Yeah.
Okay. A lot of nerves, okay? A lot of nerves, a lot of blood vessels and things like that, okay? It's an extremely difficult tumor to deal with, whether it's benign or metastatic. If it's metastatic, it's a killer, okay? If it's benign, the only way that they can really successfully get in there is if they can get through the top of the nasal pharynx to the base of the skull, they can get through that way. Or these days, there's a type of nuclear medicine referred to as a gamma knife, okay, which is like basically bombarding the tumor with gamma rays and destroying it and hoping it heals. All right, so here's the superior constrictor. These are the back of the hyoid bone. This is the middle pharyngeal constrictor here. So pretty much in this area here, what would be in front of you? This is the nasal pharynx. What's in front of this?
Oral pharynx.
The oral pharynx, okay? Primarily up here above the hyoid. Okay. And then what's in here? What's in front of here?
Larynx.
The larynx, okay? So, really, until we get to here, the nasal pharynx and the oral pharynx are opened into the nasal cavity and into the oral cavity, and they are open into your environment. So compared to, for example, a digestive tube, which is a completely closed tube, these areas are open to your environment, out, whether it's out your nose or whether it's out your mouth. And I'm sure some of you have experienced, you know, maybe taking in some effervescent beverage a little too fast, of it going out your nose, okay? But That's why when you swallow, we have to bring the teeth together to close the oral cavity. And the other thing we have to do is shut off the nasal cavity by having a relationship between the posterior pharyngeal wall and the soft palate. Therefore, we can have a more successful swallow, the tongue can be more efficient in terms of sliding the food back into the hypopharyngeal, posterior hyperpharynx, which this is certainly part of here, okay? So this is looking at it from the back. Here we see some muscles here that are associated with the soft palate. This one here is actually on the outside, that's coming down and looping around this little hook on the medial pterygoid plate called the annulus, and that will tense the lateral borders of the soft palate. That's called the tensor palatini muscle, okay? And then we will have another muscle that comes down here. Let's see if he's... So what do I see there? That is attaching to the top of the soft palate. And that would be the levator palatini muscle. Okay? So I guess what he's trying to show here is the styloid muscles. Here's stylohyoid coming down, and here's stylopharyngeus coming down. So it's a little bit of an idea. The next slide will make a little bit more sense. Here's medial pterygoid out. Here is the digastric muscle also coming down. Here's the basilar. Bless you.
Thank you.
All right, this is better. All right, so now we've got this cutaway here, and we've got these same muscles, superior constrictor, middle constrictor, inferior constrictor. Here we have the soft palate. This little structure here is called the uvula, okay, or the musculus uvula. And then we've got structures that are going to come down to the top of the soft palate, okay, alongside the auditory tube, and then it's going to come to the top and help lift the soft palate. That's the levator palatini, and then a muscle that's going to come down to the side. That's the tensor palatini, and then this muscle here is a muscle called the palatopharyngeus, coming off to the side. Okay. All right, and then we've got these styloid muscles down here, pharyngeus and stylohyoid. So these are muscles looking from back forward. Here's the lateral pterygoid attaching to the condylar neck. Okay, here is levator palatini on this side coming down to the palate. Here is the tensor palatini coming around the annulus right here, attaching to the soft palate. Okay, and I'm sure I don't want to repeat too much. I'm sure Dr. Will talk about these. This is looking at a sagittal view. Here, once again, here's the pharynx. This is the pharyngeal musculature, superior, middle, and inferior pharyngeal musculature. This is all skeletal muscle. Now it's covered with mucosa. Here's the soft palate. Here's the musculus uvula in here. Here's the auditory tube up here. Then you've got mucosal covered muscles here. One of them is referred to as the palatopharyngeus, and one of them is referred to as the palatoglossus. Okay, so here's the palatoglossus, and this is the palatopharyngeus, and then this is a tube, and the anatomical name for a tube is salpinx. So this is called the salpingopharyngeal fold, and it comes down and meets the palatopharyngeal fold. In here is a muscle called the palatopharyngeus, and here is a muscle called the salpingopharyngeus. And they come together. Now, in the digestive tract, when Tim talked about movement through the digestive tract, did he talk about the difference in movement in relationship to the circular muscle versus the longitudinal muscles? That the longitudinal muscles are pretty much pushing things along, where the circular muscles were kind of working to help form little sacs in colon, but also to help to mix things up in the small intestine, okay? Well, these muscles here represent the circular muscles. These superior, middle, and inferior pharyngeal constrictor. These muscles here and here, these muscles are the muscles that basically are pushing things out of the oral cavity and down through the hypopharynx. These are the longitudinal muscles, the salpingopharyngeus and the palatopharyngeus, okay, are doing this.
So what happens when there's a gag reflex?
Two things can cause it. One, that the nervous system said, no, you're not gonna swallow that, are you? Or you're gonna get something in there that irritates the tissue enough, so instead of being a swallow, okay, continuing to swallow, the pharyngeal musculature is going to constrict and try and keep it out. The other thing that does that is certain entities, in particular alkaloids, and one of those, I think I told you this already, it's interesting that in our society, we drink a lot of coffee. Coffee is actually one of the alkaloid substances that doesn't seem to kill us, but most other alkaloids are toxins. Okay? So, you know, you could switch to tea, or you could keep drinking that coffee. Okay? So if something hits those chemoreceptors, in particular in relationship to basic pH, so to speak, of the substance, it will cause a gag reflex. If something, let's say a sharp or scratchy or bony hits those surfaces in the back, that will also cause you to say, nervous system to say, no, that's as far as we're going. Okay, it doesn't mean you won't swallow it per se, but it will try to keep you from swallowing and having you put it back out on the table. Or, just, the process of vomiting, that's not necessarily the world, but it can be elicited from just starting as a gag reflex. But it's usually something that causes gastric irritation, and the stomach says, we don't want that in here either, okay? And so you get an opening of the gastroesophageal junction, and you get regurgitation of whatever is in the stomach. So again, once again, it could be chemoreceptive, it could be just something that irritates that stomach in that individual. Sometimes it probably has to do with some type of allergic or sensitivity reactions in certain patients, but for the most part, it doesn't matter. It's going to be, body's going to try and get it out. And you could try this on yourselves. Like take that toothbrush and try and brush your uvula with it. See what happens. All right. Okay, so once again, we see this relationship here in a cavern. This is the dorsum. This is all sensory surface. So this up here is, let's see if we can get kind of a range where the tonsils are. Probably about right here. So from here back to here, this is cranial nerve 5, general sensation, mandibular division. Cranial nerve 7, special sensation for taste. We get back here, and we've got the glossopharyngeal nerve. This is the posterior 1/3 over here. And so this is for general sensation and also for special sensation, okay? And probably with both of these, chordotympanic branch of 7 and glossopharyngeal branch, it has a relationship to the secretomotor aspect of the mucosa, okay, or parasympathetic. Then we get down in here. Here's the epiglottis. This is the root of the tongue, okay? This is vagus innervated. I think I showed you. I know I showed some of you who were in the lab the other day. That there is this superior laryngeal branch of this, the vagus nerve that gives out this interlaryngeal, and I showed you the fibers coming into the root of the tongue in one of the heads they took out of the bucket. So those are things that are coming up actually from about here, and coming into this space from a lateral perspective. Here's the genioglossus. Okay, now, you notice how there's this kind of fatty infiltrated area here? So you're gonna see that, in the cadaver and the tongue. We're gonna do sagittal sections while you're gone away resting. I'm gonna do some sagittal sections. We have some already, but I'm gonna do some more cleaner cuts. So everything from here to the dorsum of the tongue, that's intrinsic muscles. So the intrinsic muscles go in a variety of different directions. They go from the root of the tongue to the tip of the tongue. They go from the lateral border of the tongue to the midline raphe of the tongue, because it's a bilateral structure actually. And then there are vertical fibers that go down from the dorsum inwards. That's why the tongue can do what it does. Can any of you roll your tongue? Okay. That's genetically inherited. So next time you're visiting with your family, you can see, okay. Instead of doing, one of these DNA tests, you can find out just by seeing who can roll their tongue. The others are just imposters.
Is it dominant, recessive? Is it like a dominant trait or recessive?
What about
Do
being
we
able
know?
to do orthogonal?
The inheritance?
We know that it is a genetically transferred trait. Okay.
Hold on, like a second. Hereditary strength, is that inherited?
All right, so then here is the hyoid bone here, okay? So when you're looking at the cadaver and you see the sagittal section, don't look up here for the hyoid bone, look back here, okay? Look back here, here's the hyoid bone. And then here's the superior genial tubercle right here for the genioglossus, and here's the inferior genial tubercle for the geniohyoid, okay? And then here's the mylohyoid. What's this?
The inferior and.
Anterolateral digastric. Okay. To get that, you have to be actually probably a little bit off center with a cut. Okay. Because if you're dead center, you're probably missing. Okay. So over the course of time, there have been several theories of swallowing. Okay. Several theories of swallowing. Of course, I'm going to have you responsible for every theory of swallowing that there is. Okay. Actually, this is just a point of information. Okay. But there is one in here that is considered to be the most accurate concept. Okay. So swallowing is the process of deglutition. Okay. Like taste is gustation. Okay. So deglutition or swallowing. It's been explored for a large amount of times, even with radiographic things called synfluororadiography. But basically, it's kind of, I don't know if any of you were old enough, that if you went into a shoe store, they had this machine in the front that had two openings so you could see your feet, and that it was basically an X-ray machine. And you could see the bones of your feet. Now, because of all of the people that wound up with cancer, associated with chronic exposure to radiation, when they found that out, those left the shoe store real fast. Okay, but that's synfluororadiography, basically in real time, to see this radiographic image of the bone or bones associated with one part of your body. So they were able to actually follow a swallow by, maybe throwing some little radioactive, not radioactive, but radiopaque dust in there so that you can see the object that you swallowed.
Spider-Man.
Here's what I would tell you about medicine today, okay? If we did any of the things in medicine today in relationship to research that they did when I was growing up, so to speak, and that was a long time ago, okay? They would be sued for malpractice and probably for hundreds of millions of dollars. Okay, so that in some ways that was a good point in time, but because of some of the consequences of the experience, it was a bad point, especially for the subject. All right, so theory of constant proportion. This is based upon looking at animals and looking at their pairings and basically saying that the food bolus in these pharyngeal regions had to be an approximate size in order to be successfully swallowed. The bolus is what the tongue helps form before it is swallowed. So there is a pre-phase when you form this bolus, okay? To go through the upper digestive tract, and basically 3 phases. Okay, the oral phase, the bolus is formed, transformed by voluntary control, transported under voluntary control of the pharynx. So the pharynx is kind of grabbing hold of the bolus and then pushing it down into the esophagus. The pharyngeal phase, which is following the receipt of the bolus, the pharynx is activated to propel the food to the esophagus. So this is the peristaltic wave. Okay. The esophageal phase is the passage of the bolus down the esophagus to the stomach by the esophageal contraction. Okay. Now this actually held up for a long time because it makes a lot of sense. But one of the things, they tell you, have you ever gotten something caught in your throat or basically in your esophagus? Okay? And your esophagus will continue contracting until it gets it to the stomach. If it doesn't get it to the stomach, that's really annoying for one thing, but it's also if it's something sharp, let's say like an endodontic file, okay, that could push that endodontic file into the esophagus and actually through it. Okay. So anything sharp, swallowing things that are sharp, bones, fish bones, things like that, they can create some type of a chronic swallow. Yes?
We're talking about smooth muscle and it's proprioceptive. Any stretch is going to necessitate the contraction until there's no stretch, right?
Exactly. Because all muscles, when stretched, contract.
So as long as it's there, it would,
Right? But what the esophagus wants to do is it wants to get it to the stomach. Okay, so this is probably one of the more interesting ones. The series states that the bolus of food is thrown into the stomach. It's just that that tongue is just flinging that bolus of food back into the oral cavity, down into the esophagus, and throwing it down into the stomach by this force generated by the musculature of the tongue. That went away real fast. Okay. The theory of negative pressure. Now this makes some sense in particular in relationship to the way neonates swallow and suck, because as the lips are closed and the liquid is coming into their mouths, how that liquid is being drawn into their mouth is by pulling their tongue backward and creating a negative pressure in the oral cavity, which assists in moving the food into the mouth. Okay? So this is also accentuated by the descent of the larynx. Okay? Actually, the larynx is brought anteriorly and superiorly, so that didn't really work very well. So due to this negative pressure, food is supposedly sucked in. So instead of being thrown down there, it's sucked in from the mouth of the esophagus. So there's some truth to that, because liquids, that we still really do that to a certain extent. Okay? But we don't do it as much as a neonate would do it in order to get the food into their oral cavity. Then we've got the theory of integral function. This is the one that was studied by synfluororadiographic and myometric, in other words, taking sensors. And these sensors weren't little transistors at the time. They were needle sensors that were put on the outside of the esophagus. Okay, so the series based upon synfluorographic and myometric electromyography studies that considers the active deglutition as a total dynamic process. Of course, this probably got him the Nobel Prize, just that sentence. This is currently accepted theory and is described as such. Okay. Once again, here's the synfluororadiographic studies. Okay, so here we form the food into a bolus. The tongue basically creates this slide. The food then slides back here into the oral pharynx. Here the soft palate, just by the act of swallowing and tongue moving back, will probably get pushed up a little bit. But also, there's this thing that has been talked about for years. Actually, this was a researcher who was at Northwestern. They actually named a building after him. Okay, his name was Passavant. And Passavant did all of these studies on swallowing. And he thought what he was seeing was that there was a bump that was here on the anterior surface of the upper pharyngeal mucosa, and so they named it after it. They called it Passavant's pad, okay? But really that's not what was happening. What was happening, as something hit the pharyngeal wall here, that stimulated the act of peristalsis, and as these muscles contracted, they formed a bulge that when the soft palate rose, it helped to close off the nasal pharynx from the oral cavity. So that's why I say it's more urban legend than truth, but Passavant certainly got a lot of credit, including a building out of it. So then this here, you would get a bulge between the soft palate and between the posterior pharyngeal wall, called, described by some as Passavant's pad. Okay? Then, once the bolus now goes down here into the hypopharynx, once it's in here and gets past the skeletal muscle, as long as it's in the esophagus, the peristaltic wave will continue until the esophagus is clear. If the esophagus doesn't clear, it will continue to try and move that food bolus into the stomach. Now, in this case, sometimes that will create such an irritation that the individual wants to try and vomit it out as opposed to swallow it. So this theory here is the reigning theory. It's got several steps. I'm not going to bore you with that because they are each, I think, when you're writing things, if you write long enough, people will believe you. Remember that if you get a paper. So first stage is the preparation phase. Once again, that's kind of like the food bolus positioning. Also, what they learned from this is that swallowing really takes place on the lateral aspect of the tongue and the larynx. And these spaces are kind of like triangular shaped troughs. And they call those the pyramid recesses, or the pyramidal recesses, okay? So it kind of funnels the food down from the lateral posterior aspect of the larynx and into the esophagus. Okay? And that takes a long time to prepare the food, and that's, this is 2 paragraphs. This is, okay. And then the oral phase, introducing the withdrawal of the soft palate. The withdrawal of the soft palate would mean soft palate is lying down, possibly even some of you hitting your tongue. Okay? And it is raised up to provide some space, some retropharyngeal space for the food bolus to pass and get down into the hypopharynx. Okay? So, but during this now, swallowing, maybe some of you, depending upon how savory the food is, may, just roll it around in there a while, because it's something that you really like, or something like that. And before you actually push it back into the oral pharynx, okay? But while you're doing that, in order to still swallow it successfully, your teeth and your lips have to be closed. Otherwise, it's going to create an issue with the swallowing. And you did this a couple times. Try swallowing with your mouth open, okay? Not something that is readily done. And if you had something in your mouth, you would probably push it out as opposed to swallow. Then this pharyngeal phase, the pharyngeal phase is once it gets into the upper area of the pharynx, once you get past the skeletal muscle of the esophagus, gets into the smooth muscle wall of the esophagus. Once it's there, it's going to continue to be pushed down and into this gastroesophageal sphincter, through the gastroesophageal sphincter. All right. All right, so now we're gonna do another 2 hours, right? Okay, so, these are things, I mean, and just like, I was saying with, like a bimaxillary protrusion in an individual, that they develop that, there's also things that happen where there's so much separation in the anterior by this, that there's an open bite in the front. Has anybody talked about open bites yet? Facial growth, they talk about open bites? Okay, now the tongue is involved in this. The tongue is a very powerful muscle to have sitting in your oral cavity. We talked about this a little bit in the gnathostomatic system. The lips and cheeks are pushing inward on the dentition. The tongue is creating a force on the inside, pushing outward on the dentition. That has to stay balanced. If those muscles are hyperactive, potentially hyperactive lip and cheek muscles can intrude the dentition, okay? Can push it lingually or palatal, okay? From the same aspect, the tongue can push the dentition protrusively and basically cause flaring of the dentition and possibly creating a space between the upper and lower particular incisor dentition. Okay. So sometimes this is a neuromuscular problem that happens in a young child that you may or may not be able to get rid of. Sometimes the open bite is due to just sucking on something constantly, like their thumb, and creating the space. But it's worse if it is a developmental problem where the tongue, the musculature, the neuromusculature of the tongue is constantly causing the tongue to push outward on the dentition. Okay? And that's called retained infantile swallowing. Why infantile? Because typically in the neonate, the lips are closed, the tongue goes forward, and then it goes back. Okay, but this chronic anterior posture of the tongue is pushing on the dentition and possibly causing open bite. Okay. The other thing in relationship to that, problem is that, so what if it is tongue thrusting is what a neuromuscular problem is. How are you going to try and correct that? Well, you can try and correct the neuromuscular aspect by putting all kinds of devices in there to try and convince the tongue that it shouldn't go forward. Okay, these are typically called tongue cribs. The tongue crib is usually a pointed object that's put on the back of a fixed prosthesis. It can either be placed by the dentist or the orthodontist, that every time the tongue hits it, it feels sharp spikes sticking in it, and it pulls back, okay? Sometimes it works. Okay? Sometimes it works, and the tongue, the neuromuscular system adapts to that and says, I'm not going forward anymore because I'm not gonna, after you get so many holes in the front of your tongue, you ain't gonna, plus the swelling. But there's all kinds of things, you could, a lot of pediatric dentists say, well, we'll put something on our thumb. This is kind of like, did I tell you the story about antabuse? Antabuse as a mechanism to control alcohol. Alcoholism, antabuse was something that turned alcohol into formaldehyde. So physicians thought if they gave the patient antabuse, when it got to the liver and was turned into formaldehyde and created all that pain in the liver, that the patient wouldn't drink. As they said, we're not the smartest tools in the shed. The patient just stopped taking the antabuse. They figured it out faster than we did. Okay, this is the same thing. Okay, so you take the kid's thumb and you put something on the kid's thumb, and you see him putting his thumb in his mouth. That doesn't taste good. So they put their thumb in their mouth, and it doesn't taste good, and they take their thumb out of their mouth. Or you say, you paint something on their thumb and say, don't put that in your mouth. Don't put that in, every time you see that, don't put that in your mouth, okay? Whatever, okay? But they figure out a way to do it, and then eventually they see an orthodontist by the time they're about 10 or 11, and to straighten out the problem. But then, if it's either a retained infantile swallowing or it's a problem they can't correct, if they do orthodontics, they're gonna have to put fixed retention on those dentition because the kid or the problem is not gonna go away. So they pretty much have to lock those teeth in position in some type of fixed retainer. So this stuff all has to do with dentistry. Why don't you take another 5-minute break and we'll continue on. If I can. Because the bacteria is either breathed in or it's brought in through your oral cavity, maybe on food, okay? Or by actually breathing it in through your mouth instead of through your nose. Okay? Dental oral infections can begin in a variety of oral structures and spread to other areas of the head and neck, okay? As I told you, you may think it's facetious, but dental disease can't kill a patient, okay? You gotta get them to believe that, because in some cases, the reason you gotta get them to believe that is because some of the things that you're gonna see, you're gonna say, this needs to be treated real fast. Otherwise, we're gonna have a more serious condition like some type of septicemia or toxemia. Okay? So periodontal disease, you know the transition that bacteria take in those pockets, in those sulci over the course of time. Some of them could get really nasty, okay, like Bacteroides, for example. But bacteria in the mouth, primarily strep, they actually have a synergistic environment with the other bacteria in the mouth, and you usually do okay. It's when they get out of control. Okay. Actually, what causes in periodontal disease? Do the bacteria eat the bone?
No.
How does that happen?
Not
Does that happen?
the acid they produce.
What about the effect that it has on the body to mobilize defense cells? Okay, and the defense cells are called lymphocytes, and the lymphocytes release lysozymes, and the lysozymes destroy the bone. So in some ways, it's a bacterial-induced disease, but the severe damage is caused by the attempt of the body to heal, to get rid of the bacteria. Okay? But certainly acid plays a role. All right, so here you go. Here's some teeth that, for whatever reason, this is an older netter slide. I had some problems with it a while ago because I thought his premolar here looked like a canine tooth. But here we've got lower molar. This is abscess formation. This is periodontal disease creating bone destruction. Okay, the situation here is that those bacteria don't have to stay here. If they've got some type of a conduit to move around to some other place of the body, they will move around. We'll talk about this. How are the primary ways that they can move around? They can move around by getting back into the lymphatic system and getting into the systemic circulation, or they can move into the venous tributaries and get back into systemic circulation. So this is how things can become systemic, but start out local. A lot of different ways. So, for example, in this premolar area, the passage of bacteria from one area to another can happen vertically into the axillary sinus, out here into this what's called the intertemporal space, in here into the between palatal bone and palatal mucosa, and then down here, mandibular can move out here. Here's the platysmal muscle. You wind up going between the platysmal muscle and bone. You wind up going on the inside of the buccinator muscle here. You wind up going into the area underneath the lingual mucosa here. So there's a lot of ways that bacteria or the process of inflammation or drainage can take place. Okay, so I threw this in here just to see if you remember it. Okay. Ruber, Calor, tumor, dolor, functional asia. Okay, that's signs of inflammation. That's signs of wounds. Okay, whether wounds healing or wounds that have recently been created due to some type of infection or some type of trauma. Okay, Okay? Remember, there's no such thing as a simple infection. If you got an infection, you got an infection. The infection doesn't go away, okay? It's gonna get worse somehow in that individual's system. So there's no such thing as a simple infection. Actually, we had this committee meeting where we were talking about clinical affairs, and Dr. Bauer is on the committee, and we were talking about extractions. And somebody in the room said, yeah, well, we need to set up a way so an emergent patient, we could deal with simple extractions. And I said, there are no simple extractions. You'll find that out too. Probably the hard way. Okay? They just don't, you just don't look at it, it pops out of the alveolus. You actually have to do some work to get it out of there. And sometimes you have to section the tube, sometimes you gotta split it down the middle. There's no such thing as a simple extraction, just like there's no such thing as a simple infection. And that's something that you really want to be sure that's brought under control fast. Okay, so the structures which can spread or contain or limit the spread of infections are the skin. We can get the infective process trapped under the skin. Some individuals call this cellulitis. It's kind of a bad name. A lot of people don't really like using that term, cellulitis, but sometimes in subcutaneous infections, that maybe even something that's caused, let's say, by a bee sting, okay, cause swelling, cause pain, cause some type of redness, fascia. Okay, we'll talk about this significantly. Fascia is a big one, okay? We talked about fascias before, okay? We talked about superficial fascias. One of the things about superficial fascias is they have fat, okay? Superficial, anywhere on the body, they have fat. Superficial fascia in the face is also unique because it surrounds skeletal muscle. That's the only place that it does that, that it holds skeletal muscles together, okay? Deep fascias, on the other hand, are holding structures together. Whether that happens to be a skeletal muscle, smooth muscle tube, whether that has to be smooth muscle tube like a blood vessel. It helps nerves together in nerve sheaths and things like that. But the fascia, basically there's a potential space between the fascia and the muscle, or the fascia and the structure, but there's also a potential space between different fascia layers, and we'll see how this applies to the neck. Okay. So the muscles, a muscle can limit because it has attachments to bone. So if you get an infection, for example, between the muscle and bone, it can get trapped there. Now those typically, one of the things you'll find about that is when you get an infection that's causing swelling between the muscle and bone, those are typically painful types of processes because it's stretching the muscle artificially, okay? As opposed to, let's say, you get an infection on the outside of the muscle, between the muscle and skin, where that skin could just be pushed apart, pushed apart, pushed apart, okay? Venous channels can both bring bacteria into the systemic circulation, but also move it from one place to another. Lymphatics, we talked about lymphatics a little bit. Lymphatics have these little entities along their paths called lymph nodes. Okay, lymph nodes can become active if they are reacted to by a foreign entity, and they will try and stop that entity from getting into the circulation. So these are structures that can play a role in this process of the infection. Okay. All right. So once again, we have these fascias. Okay. We have superficial fascia, always contains subcutaneous fat. Doesn't matter where it is in the body. Okay. We're talking pretty much. It really has. Once it gets off the thoracic wall, there's actually a significant amount of deep fascia that's holding these structures together. For example, the carotid sheath, okay, or the scalene muscles, or the brachial plexus, or sternocleidomastoid, trapezius muscle. There's a lot of deep fascia involved in those structures. Deep fascias can be subdivided. Usually as a group, they're not only called deep fascias, they are called cervical deep fascia layers or deep cervical fascia. So the superficial most is called the investing layer, and we'll see that surrounds pretty much the trapezius muscle and the and the sternocleidomastoid muscle, okay? But outside of this, outside of the sternocleidomastoid, if you remember we was looking at it in the lab, what's outside of the sternocleidomastoid? What skeletal muscle is outside of the sternocleidomastoid? Platysma, okay? And so that's surrounded by superficial fascia, okay? We know that because there's fat involved, there's fat involved. We'll draw these out and look at them in some images. Okay, then there's a layer that's called the middle layer of cervical fascia. Now we have this laryngoesophageal region, okay? And we have these muscles on the front of the trachea and front of the larynx that are called the infrahyoid muscles. Those are skeletal muscles. They are held together and surrounded by a deep fascia. Okay? Since the thyroid gland is there also and is covered by those muscles as well as some fascia itself, sometimes this is called the visceral portion of the deep fascia because the thyroid gland is a visceral entity, but also the airway and the esophagus are visceral entities. So these come around, for example, around the front, the sides of the trachea and larynx, and around the back. They come around this muscle called the inferior pharyngeal constrictor muscle, and they surround those structures there, and they form basically a tube, okay? But they are kind of a little layer inside of the intestine layer, especially in the front. Then there's the deep layer of deep cervical fascia, and this is called the prevertebral fascia. This is the fascia that's on the anterior surface of the vertebrae themselves. Now, why is that? Well, vertebrae are bone, right? Okay, they're covered with periosteum. But what muscles are in the front of the cervical vertebrae? What about the longus colli and the longus capitis? They're right on the front of the bodies of cervical vertebrae. Now in the back of the cervical vertebrae, there are a lot of muscles. There's trapezius outside, which is surrounded by superficial fascia. You go a little bit deeper and we get muscles like splenius capitis that are attached to the head, semispinalis capitis. Those also are surrounded by deep fascia and come around the lateral borders of the cervical vertebrae. Okay. We'll look at some other areas just in terms of terminology. What does the term ala mean? Like a wing-like. So these are wing-like fascias. We'll see how they play a role. They actually help to form this structure, the carotid sheath, which is a fascia tube, okay, that surrounds what?
Colon carotid, into the jugular and the vagus.
Okay. Anything on the outside of it? Any significant structure on the outside of the carotid sheath?
The sternocleidomastoid.
The antecervicalis formation, the portion of the cervical plexus. Then remember, that lies on the outside of the sheath, the vagus nerve is in the sheath. What's behind the sheath? You should pay attention to these things I keep repeating. Okay? Sympathetic trunk. This paravertebral chain of Then the retropharyngeal space is actually a space we talked about before, that the posterior pharyngeal wall, the front of those superior, middle, and inferior constrictor muscle, is lined with mucosa. Okay? Lined with the secreting membrane, this mucosa. But on the deep side of those muscles is fascia. And between that fascia and the vertebrae is a potential space. And since it's behind the pharyngeal musculature, it's called a retropharyngeal space. The significance of it is that it extends not only from the pharynx down into superior pharynx, middle pharynx, inferior pharynx, it extends in the posterior mediastinum. Any type of infective process that gets into the retropharyngeal space, potentially over the course of time uncontrolled, can get into the thorax. and into the area of the retropharyngeal space goes into the posterior mediastinum. What's in the posterior mediastinum? Anything you remember? No, esophagus, lungs, heart. Heart's in front of the posterior mediastinum. Okay. So if you thought dentistry was just about teeth, you were far from it. All right, so let's talk about these fascias. This is just, what's fascia? Again, fascia is a loose areolar connective tissue, okay? Helps to wrap, hold things together, provides a barrier against the spread of infection. What else is in fascia? I don't know, Dr. Candler ever talk about the histology of fascia? Ever talk about it at all? What kind of cell type do we find in these, in particular, these superficial and deep fascias? It's actually a defense cell. You know what it's called? It's called a fixed macrophage or a histiocyte. So the body is trying to set up some barriers to try and protect itself if things from the superficial surface break through that surface and try and get deeper into these soft tissue entities. So fixed macrophage or histiocyte is found in fascia. Okay. All right, so Marie Antoinette is going to help us with this description. Okay, so we cut off her head, just about at the level of the junction between the esophagus and the trachea. Okay, I don't know exactly how that, whether that was how the guillotine worked. I know sometimes it slipped, but basically, you lost your head. What's the movie that's out down there? Is it Mary Queen of Scots? Mary Queen of Scots. She was, when Elizabeth I did not like her. She felt threatened by her, and she was convinced to have her head cut off. So it wasn't Henry VIII, but it was
The
Elizabeth.
section's not the problem here, the bows and the pigtails. Why would you include that? There's totally, and that makes it so much worse.
I didn't do the drawing. I didn't do the drawing.
You just disfigured a small child.
Are any of you French descent? Are any of you of French descent? French had a great way of execution. They had the guillotine and they had the garrote. The garrote was a kind of a specialized type of hangman's loop that when the person dropped, it broke their neck at the junction between the first and second cervical vertebrae. They were really good at stuff like that. I don't know if it's something to write home about, but. All right, so here we see some of these layers in a schematic. And we're going to draw this in a minute. But here's the platysmal muscle out here, and it's a large flat muscle. It's sitting on the outside of this muscle here, sternocleidomastoid, and it comes back along the anterior region of the trapezius muscle because they both come from areas close to the shoulder. But this is superficial fascia that this is wrapping. Then besides blood vessels and nerves coming through here we have this fascia that's attached to the sternocleidomastoid and then comes back and is attached to the trapezius muscle here. Okay? So this is the outermost layer of deep cervical fascia called the investing layer. Then in this anterior portion here, which we've got as cut sagittally, we have these infrahyoid muscles here, sternohyoid, sternothyroid, thyrohyoid, and so forth, omohyoid in here, that are held together with a deep fascia. They are out in front of, really what sits in here is the thyroid gland, sits in here. That's also covered. They then kind of form a circle or a loop with the fascia that surrounds the skeletal portion of the esophagus here. So this is part of the visceral tubular area, or the pharyngeal muscles associated with the esophagus, but also the muscular layer associated with these infrahyoids. And then also in here, excuse me, you have the airway, okay, over here, and you have the esophagus, you have the food tube that's surrounded by this as well. So these are also visceral fascias, these are visceral tubes. Then we have the vertebrae over here. The vertebrae have muscles on their back, like splenius and semispinalis capitis and longissimus capitis. And they come across the back of the vertebrae, but also across the front. There are two muscles in here, longus capitis and longus coli. And so they are layered with fascia, and those are called the prevertebral fascia, or the deep layer, deep cervical fascia. And then there is this potential space between this visceral layer and this vertebral layer that's called the retropharyngeal space in here, okay? And then we have this fascia too, called the carotid sheath. Now, if you notice, coming off of here, and off of here, and off of here, there are wings of fascia that help to form the carotid sheath. Those are the alar fascia, okay? So let's kind of draw this out. I don't know whether to draw it on paper, or I guess I don't have any paper, so. Let's try and draw here on the slide. Okay, let's do this. Okay, and let's put in here. Let's put in here a slide here. Okay. So let's look at this from this perspective. Hopefully this cooperates with me. All right, so, no, it's not going to cooperate with me. Let's see. Okay, that's good. Okay, so we're going to have out here,
What are you drawing?
I'm drawing a circle around the neck, okay?
You can understand.
So the screen's not.
It's not on the screen, that's probably because it's on.
You could just point with a pointer, it's helpful that way too.
Okay, thank you. Okay, let's try this.
Now we see it.
Yeah.
Do you?
Wow, okay.
All right, so in here, we've got, nothing, it's a move.
No, never mind.
Let's get the long stock again.
This is maybe not funny.
Okay, we've got a muscle, got a muscle in here.
Sorry. It looks like something about.
Okay, and this is the platysma.
I don't think this is working out.
No. Okay, let's do something here. Okay, so the platysma is surrounded by this fascia, which contains fat. This is superficial fascia. Okay, so the platysma muscle is a muscle of facial expression, and all muscles of facial expression are held together with fascia. Okay. All right, then we've got a muscle here. It's more anterior in position, over here. Okay, And this muscle is the this is the SCM, sphenomastoid, okay? Then we've got a muscle back here. That is along the back. And over here, let's draw something new. Okay, so this muscle is coming across like so, and this is the trapezius. And they are covered with fascia. Okay, so they are surrounded by fascia, and they are interconnected to one another. And this is the investing layer. And then we've got some structures in the front. Okay, we've got basically and so this is the trachea. And this is the esophagus. Babies. And in the front of the trachea, we have these muscles over here, they're paired on each side. And these are also surrounded by fascia. And then the tubes themselves are held together with fascia. And then these fascias join the esophagus, which is also surrounded by fascia. Sorry. It's all right. Okay, and these tubes are basically visceral tubes or muscular tubes. Okay. So this fascia is referred to as the muscular and visceral or middle cervical fascia. Okay, and then we've got fascia associated with muscles that are in the front and back of the vertebral column. And they are surrounded by fascia. And the other muscles that are back here, like scalenes and so forth, they are surrounded by fascia. And they create a fascial loop around here. So this is the prevertebral fascia. Okay. So those entities really are the subdivisions of superficial layer, deep cervical fascia, the investing layer, sternocleidomastoid trapezius, middle layer cervical fascia associated with the infrahyoid muscles and the esophagus and the trachea, larynx, and the muscles surrounding the vertebral column or the prevertebral fascia, the deep layer or deep cervical fascia. Well, also what's going on here you've got this fascial tube, bilateral, it's one here and here, okay? This fascial tube, and within this fascial tube, is a large venous structure. Artery. And a nerve. Okay? And this is the carotid sheath. Okay. Now, each one of these tubes is held together by deep fascia. The vein is held together with a conjunctival covering called deep fascia, or the conjunctiva of the artery, the same thing, conjunctiva of the artery, and the nerve is covered with an epineurium, which is deep fascia that surrounds nerves, okay? What is also happening to help form this sheath and anchored in place is there are fascias coming off of the prevertebral layer, coming off of the middle layer, and coming off of the investing layer, and these are what we refer to as alar fascias. So that's what forms all of these layers. Now between these layers is spaces. And once again, between these fascia spaces, these are tissues that have within their confines, they have some strength in relationship. They're, loose areolar tissues, but they are still strong enough to resist the pressure of some bacterial entities that cause the formation of an exudate, like pus. But that pus could get caught between these layers. Okay? One of the places that it gets caught between is this this space here. Between the middle cervical fascia and the prevertebral fascia, and this is called the retropharyngeal space. Okay. All right, so based upon how this thing's been working for me, that's not bad, all right? All right, so let's continue and look at some other things. This is it, okay? This is what we're trying to illustrate here, was these spaces here, but this is a cut, okay? This is a cut where a head has been removed from the body, and here's the anterior, and here's the posterior, okay? Here is the this is the vocalis muscle cut right at the level of the larynx, okay? So, this out here in the front, subtly a portion of the thyroid cartilage. Back here, this is actually part of the greater horns of thyroid cartilage. And then we have in here the airway, and here and behind the airway we have the esophagus, and behind the esophagus we have the posterior pharyngeal musculature of this area referred to as the inferior pharyngeal constrictor muscle. Okay? Here is the vertebrae, here's the vertebrae body, here is the vertebral canal with the spinal cord inside of it, here is the lamina, and here is the tubercle. Remember, cervical vertebrae, typically don't have necessarily a spine, at least high up. This is actually probably around C5, so there's a little bit of a split or bifid spine here coming off of the lamina. Okay, what are these structures? What do you think those are? This is a vertebral body. Vertebral artery and vertebral vein, okay? So we see the relationship. Here is the platysma muscle. You can see a little bit of it out here in the fat. These are superficial venous channels. Here in the fat, in the subcutaneous layer. Here is the carotid sheath. Here's the internal jugular vein, and here's the carotid artery. We don't really see very well the nerve in here. It's pretty much right about here on this side, okay? Here's the sternocleidomastoid muscle and the trapezius muscle back here, kind of surrounded by fascia but interconnected to one another in this investing layer. Here are your infrahyoid muscles here, sternohyoid in particular, a little bit of thyrohyoid, maybe some omohyoid here. Okay, so we have that. Then we have all of these muscles that are wrapped in fascia that are on the back side of the vertebral column, but the fascia comes around these two muscles here. This is longus colli. Okay, and they are covered with deep fascia. So this is the prevertebral fascia. Okay, this space between this posterior pharyngeal wall and this posterior the anterior surface, of the vertebrae, that's the retropharyngeal space. Okay, that's the retropharyngeal space. Now, where with these pharyngeal musculatures, we talked about that the superior pharyngeal constrictor muscle had a great relationship with a muscle in front of it. What muscle was that? Buccinator. So sometimes this layer, as we go up higher, you'll hear the term buccopharyngeal curtain. Buccopharyngeal curtain. The buccinator in this oral cavity region in particular, along with the superior constrictor, are forming a wall, helping to form a posterior wall of this pharyngeal region that is in front of, this is the pharyngeal constrictor, so this would be inferior and higher, middle and higher and superior, trying to form a wall in front of this retropharyngeal space. We can see some of these alar fascias. Here's an alar fascia here coming off. Here's an alar fascia here coming off, okay, and an alar fascia here coming off. So this is real. This is what we see in the cadaver. This is where they got this stuff from. Actually, if you want to read about fascias, I've got 2 papers that were written in the 1950s. Each one is 150 pages long. Okay. So this is a short lecture compared to those 2 papers. All right. If you take the muscles away, you're left with the fascias. Okay. You take the muscles away, you're left with the fascia. This is an artist illustration. But here we see the thyroid cartilage out here. Here is the laryngeal cavity. Over here, here's the esophagus. Here is this layer of middle cervical fascia called the visceral layer, and this, or an upper that's up higher called the buccopharyngeal curtain over here. Here are like longus coli and longus capitis. So I don't really agree with that because longus capitis really starts real high, but the longus coli is definitely down here. Then we see muscles, muscles like the scalene muscles and the levator scapula muscle and the trapezius muscle and the sternocleidomastoid. Here's the platysma and the superficial fascia here. Okay, but also showing the nerves. Here's the carotid sheath with the, usually the deepest structure is the internal carotid or common carotid artery, and then the vagus nerve, and then the internal jugular vein. Okay. So, in between these surfaces, in between these fascia-covered muscles, theoretically, depending upon the path of least resistance, and that's how infections move. They move through the path of least resistance. As they are building or creating this exudate, this pus, they can push these tissues apart and move through these tissues. Okay? So, muscles can can help to resist that movement. So can fascia. Okay, so let's look at this. This just shows here. Here's a sagittal section. Excuse me. Here is the airway, and here is the esophagus, and then here behind this retro or buccal pharyngeal curtain, as we come down, here's the larynx. Okay, there is the retropharyngeal space. Okay, and there, sometimes they say that as these wings of fascia come from each one of these layers, they form another layer, which is sometimes called the winged layer or the alar layer. So sometimes there's two layers of fascia in here. There is this buccal pharyngeal fascia, and then there's an alar fascia that was coming out to the sides. I could actually, I don't know if, I'll probably have to take another head off to show you that. Okay, we had one that was around for years and years and years, but I think we had to have him cremated this year. So here's the retropharyngeal space, here are the lungs here. So this is back here behind the airway, behind the esophagus, into the posterior mediastinum area, this retropharyngeal space. Okay, so once again, if we look at this here, this is what we're seeing, but this is together. These are potential spaces between the fascial layers. These are potential spaces between muscle and bone, between muscle and fascia, okay, that take place here. So here's the pharyngeal constrictors, okay? So here's the oral cavity, the buccinator would be coming around back here. They both attach at a bony point on which bone? The spirit constrictor and the buccinator. What are they attached to? Besides attaching to each other, they attach to a bony process on the sphenoid bone. The hamulus, you said, I think, that you saw. Oh, you said. Okay. The hamulus, okay, that's one of the bony anchors out to the side laterally. Okay, so the front of this is mucosa. This is mucosa, this is a secreting membrane, okay? Behind this, associated with the muscles themselves, is fascia that's holding the muscle together. That is part of the middle or visceral layer of the middle layer of deep cervical fascia. Okay. That is surrounding that. And then on the anterior surface of the vertebrae are these, just barely see it because this is really right at the midline, and then what little lateral is the longus coli, and up here the longus capitis. Longus capitis up here and longus coli.
Bless you.
Thank you.
All right. So here's the frontal section. Okay, so molar, these are the roots of molar teeth, and maybe a second premolar back here. Probably just first and second molar and possibly a second premolar in here, okay, that are in the maxillary sinus, okay. So here's what I would tell you, okay. Teeth can cause a sinusitis, okay. Teeth can cause a sinus abscess, okay. A sinusitis can lead to dental pain. Maxillary sinusitis can lead to dental pain. They have that relationship. The nerves are actually running down into the root apices, or from the root apices, as branches, in his case, of the maxillary, either posterior superior alveolar or the middle superior alveolar. Okay, we're not far enough forward in the answer. Okay. Nasal infections can lead to sinus infections, can lead to tooth-related infections. You know, so all of these things are in close proximity to one another. When you're dealing with somebody that is in pain, get the whole picture, okay? What type of radiograph might you take to find out if you got a sinusitis? Panoramic, okay? You don't need a cone beam CT, okay? You don't need a $1,500 radiograph. First of all, the insurance company probably won't pay for it. Second of all you need to determine is whether you've got a cloudy sinus or a clear sinus. But you might also see what happens in chronic sinusitis. You see mucosal swellings that stay in place and actually create a cystic cavity that's called an antral polyp or an antral cyst. This is the antral. This is the space of the sinus. Things like that. All right. So here we have the lower dentition, okay? So here is the top of the epiglottis. So this is the root of the tongue back here, okay? And here is the opening into the airway, and then here is the muscles associated with some of this fascia back here, both on the prevertebral area and also the visceral fascia. Okay, here's a palatal tonsil here, so here is the palatopharyngeus, and here's the palatoglossus over here. All right, back here, we've got some of these muscles coming to the front of the vertebrae, and so forth at this level, probably still cervical. Here are vertebral arteries over here. Okay, so what's this here? What part of the jaws is this? What specific? These are the molar teeth of the mandible. What's right behind molar teeth of the mandible? Ramus of what? Mandible. Okay. Here's the inferior alveolar nerve artery vein in here. What's this out here? What's this in here? Medial pterygoid. Okay. And then passing through this space, we've got like styloglossus coming down. We may pick up the posterior belly of the digastric coming in here. Okay. And then we've got these structures that are associated with a space between the vertebral column and the muscles that are running through here, including medial pterygoid. This is called the lateral pharyngeal space. Okay. The lateral pharyngeal space. And so here we have this vein. This is the internal jugular vein. This is a portion of the internal carotid that is passing up through here. It's not branching in here, but it's coming up to the brain. Here is this structure here in relationship to the external carotid, maxillary artery at this point, giving off the inferior alveolar artery in here, in this lateral pharyngeal space, and then running down through it to the tongue. It's actually going to run down and then come up. This is the hypoglossal nerve over here. Okay. This is the hypoglossal nerve up here. So this is the lateral pharyngeal space. What do we call the space between the medial pterygoid and the mandibular ramus? The pterygomandibular space? You heard that term? No? All right, that's the pterygomandibular space. Okay, and then we've got all of these posterior muscles here. Okay. So let's look at some of the things that can happen here with, in relationship to some of these structures. Here's muscles of mastication, muscles of facial expression. What's one of the unique things about muscles of facial expression? Muscles of facial expression have a bony point of origin, but they do not have a bony point of insertion, okay? So something could get caught under there and move around quite easily under the skin and create these entities that we call cellulitis, this subcutaneous swelling, right? So these are all like platysma and depressor angularis and depressor labia inferioris. Here's the buccinator attaching to the external oblique ridge and attaching to above to the alveolar process of the maxilla. Here's the attachment of the masseter, and here for its point of origin, but its point of insertion is on the ramus of the mandible. Not just this little puny point down here at the angle, the whole surface of the ramus. Okay. Other muscles of mastication, temporalis to the coronoid process, inferior belly lateral pterygoid to the pterygoid fovea, medial pterygoid to the angle of the mandible down here. Here's the mylohyoid, or internal oblique line with the mylohyoid attached. Here's the anterior digastric over here. So all of these muscles, whether they're facial muscles or masticatory muscles, have some relationship to bone and could create some kind of a restriction to flow of some type of fulminant infection. And that is usually manifested in some kind of a swelling. Like I was saying before, if it winds up stretching the muscle, it usually is associated also with pain. Okay. Okay, so here's a horizontal section, a transverse section through the head at the same level, really. Here we have the tongue, okay, and back here is this is a retropharyngeal space abscess. Here is an abscess on the outside of the buccinator muscle. So this is an abscess that has moved around the buccinator muscle somehow on its outside. Here's an abscess in the submasseteric space. This is a real painful abscess. This masseter is tied down tight to the mandibular ramus. If you get something here pushing it and stretching it, it's going to hurt. It's not going to want to move. It's not going to want to move because when it contracts, it's going to be resisted by the infection. Here's a parotid abscess, mumps, so to speak, paroditis in here. Here is an abscess here on the in this area. This is the lateral pharyngeal space over here, or pterygomandibular or lateral pharyngeal. Okay. So let's say you've got a situation. You've got a mandibular third molar that's abscessed. Okay, and okay, it gets to a point where the abscess has been fulminating. Maybe it was painful for a while, but then it gets to be less painful because it's draining out of the apex of the third molar roots. Then that abscess, along with whatever bacterial entity is in it, or in the pus, is going to move back here into possibly the pterygomandibular space, or worse than that, into the lateral pharyngeal space over here. And then from the lateral pharyngeal space, we can move into the retropharyngeal space. So, one of the things I'll tell you, okay, you'll be doing dentistry, and you're going to try and do good, competent dentistry, and you'll have a situation where maybe you have an abscess tooth, and that tooth is restorable, but it needs a root canal, and you yourself have taken on the task of doing that endodontic procedure, and you're going to clean out the canals, okay, and the pain you assume is going to go away. Okay? The pain you assume is going to go away. That's one of the two assumptions. The other assumption is that when the anesthetic wears off, that pain is going to exacerbate because that abscess has already been in bone. You kind of shook up the inside of the pulp chamber, and now there's going to be a tendency for increased vascular flow, causing swelling at the apex of the root. So the patient may then go home after you've successfully cleaned this out, and they're going to be swearing and calling you names that you can't hear or imagine. And, you know, what did you do to me? You were supposed to take away this pain, okay? Or things like that. Or you're going to extract a tooth. And the tooth isn't going to heal really well within the confines of the alveolar socket, and There's gonna be a clot formation, but the clot is possibly going to get washed out because the patient didn't listen to you about keeping the gauze in there for a while, or they started rinsing heavily with water, and the clot went out. So now, what do you got? You got denuded bone. Denuded bone is one of the worst pains that you can have, okay? So that is in relationship to an osteitis that's happening in the alveolar side, okay? Even though you're not trying to cause these, you're trying to solve the patient's pain problem, as a consequence, sometimes there's another problem that gets in the way, okay? So you gotta try and work with the patient, explain, okay, you know, when this is done, you gotta explain to the patient, you know, when the anesthetic wears off, you're gonna be sore. You may have them take something like Tylenol. The reason I say Tylenol is Tylenol particularly isn't an NSAID that could cause increased vascular bleeding, okay, an extraction or something like that. It may increase swelling. So you might want to start with that these days. In your generation, who knows what you're going to be able to do with Schedule IIs, okay? You may, in all honesty, the way I'm seeing things go, have to prescribe, you know, you may have to prescribe hemp or marijuana. You know, lesser of two evils, I guess. You know, I don't know about that. But schedule, this goes in cycles, by the way. There used to be happened several years ago with people that had cancer, had terminal cancers, and they were given a lot of Schedule II drugs like OxyContin and things like that. And so they got a little buzzy on that. And so people used to say, okay, we can't do that. Well, this is someone that's dying. Okay, so they finally came to their senses and said, that's okay there. Okay, but now we have some of these other issues and it's coming back on us, yes.
So, when you said like not to use the NSAID but use the Tylenol instead, you said it would cause increased vascular bleeding and swelling if you use the NSAID?
The NSAID will possibly cause increased bleeding and swelling
Can you say why?
because it mobilizes water out of cells. It's an anti-inflammatory.
So wouldn't isn't it supposed to reduce swelling though?
Yeah, but it's got to put, where's it going to put the water? It's going to put the water, it's going to put at the root apex or in the adjacent to the root apices, either an endodontic situation. NSAIDs, by the way, in older individuals can also lead to hypertension,
Okay.
okay? So where's it putting the water? I mean, it's putting the water into space, okay? All right, so this is a horizontal view. Here's a frontal view, okay? So these are all infections associated with the potential passage of some type of abscess formation into a deeper space. So here we've got a palatal, a molar with a possibly palatal root that's inflamed and decayed or causing infection. So you get this. This is also a very painful injection, a painful thing. It's kind of like I told you, what's the most painful injection? It's incisive papilla because it's so tightly bound to those nasal palatine nerves when you go in there and inject. It stretches the nerves and they get an extreme acute sensation. All of a sudden it'll go away, but not until they kind of lift themselves out of the chair and then come back down. Okay. All right, and then here on the outside of the buccinator muscle, okay, once again a parotid infection. Here on the inside of the buccinator muscle, here on the temporal, inside the temporal, it's called a temporal space abscess due to a maxillary molar probably. Abscess creeping in here. This is also, you know, the temporalis is tied down really tight to bone here. It's also going to cause a lot of pain. Okay? It's also going to cause a lot of pain. And once again, what's it doing to the muscle? If you're taking up the space that the muscle has, it stretches the muscle. What does the muscle want to do? Contract. So it's going to make it worse. It's going to make it worse. Here is a subcutaneous, or sometimes some clinicians call it cellulitis. Here's a subperiosteal abscess that you might see in periodontal disease, where it's actually deep to the periosteum, but it hasn't broken through the periosteum, so it's actually between the periosteum and bone. This is a submental space. How did I tell you you can get submental lymph nodes enlarged? What could that imply to you? The submental lymph nodes are enlarged. What would that imply to you? What could cause that?
What do they drain?
That's what I'm asking.
Mandibular and.
The submental lymph nodes are draining what? The tip of the tongue, the anterior mandibular anterior dentition, floor of the mouth, okay? Periodontitis, periodontitis, okay? Can cause it, and from a simplistic perspective. Also, you can have a cancer of the tip, cancer of the tongue, okay? So, I mean, these are things that you have to pay attention to when you're doing an exam. Now, here's the tongue, and this is a infection deep to the tongue, okay? This has a really interesting name. It's called Ludwig's angina, okay? This was described by a medical practitioner years ago. They did not have antibiotics. They did things like use leeches to control the swelling, okay? This was a German physician, he described it as the lesion has reached the size of a four Kreutzer coin, okay? He basically followed the patient until the abscess killed the patient. That was the end of the case, okay? So, Frau Ludwig got the honor of this type of infection being named after her. This is the sublingual abscess. What does it do? It pushes up and back on the tongue and pushes the tongue towards the back of the airway and could really cause a problem with breathing. This is called Ludwig's angina, or a chronic sublingual infection. I'm hoping your oral surgery mentors will talk about this. Just real quickly. Okay. Teeth are good to you, but they can also cause you a lot of grief, okay? Especially, you can tell your patients if they don't take care of it. You can show them, you can take this, keep it in your office and show them what happens to teeth that have an abscess, okay? You might even want to show them the one where it goes into their chest. Okay. When they say, well, can't kill me, can it? I said, oh yeah. So here is it's a maxillary central incisor draining back into the palate. Here's a premolar draining into the buccal mucosa. Here's a second premolar draining into the sinus. Okay. Here's the mandibular premolar. Here's the mylohyoid over here. Here's the mucosa over here. The buccal mucosa draining here below the buccal mucosa and out into the vestibule. Here is a molar draining on top of the mylohyoid. So between now the mylohyoid and the tongue. Here's an abscess of the central incisor draining forward into the labial area. It's interesting about buccal space abscesses because you see the swelling here and you assume that, if you go in and go through the skin, which is really stupid, for two reasons. One, unless you're a real great suture of tissue, you should need a plastic surgeon to do that, but you got staph out here. So you gotta do, literally, if you're doing anything out here to in here, you gotta do a surgical scrub. You gotta do 5 minutes of betadine, you gotta isolate the area before you do your incision. But more than likely, the swelling is between the buccinator muscle and the dentition, or between the buccinator muscle and the mucosa. Okay. So you might go through the skin and the pus doesn't drain. You go now on the inside and it drains. Fortunately, strep, we have antibiotics that help us easier deal with strep than it does with staphylococcus. Okay. All right, so a few more abscesses, just to wet your whistle. So once again here, now we're draining underneath the mylohyoid muscle. This actually is going to be a sublingual abscess, okay? here draining out here between the buccal mucosa, over here and the bone. So that is draining into the vestibule. So really what you have to do is you have to go into the vestibule and take care of it. Now, interesting though, the buccal space abscess, you gotta be real careful and decide where that abscess is before you cut through here. Because you can assume that it's here, okay, but it's outside the buccinator muscle. So you went in here and you made an incision and nothing drained. Because it had worked its way around the front or the back of the buccinator muscle, and this abscess was on the outside of the buccinator muscle. Okay. Here, premolar draining right through the bottom of the mandible. Now this stuff isn't made up. This is stuff that was recorded by an illustrator in relationship to studies of abscesses and patient's dentition over the course of probably 50 years. Okay, here's the tongue over here, here's the sublingual gland. Here is the oral mucosa. This is on top of the monohyoid, so it's pushing up on the oral mucosa. It's actually between the tongue and the lingual portion of the mandible. So these are things that you have to think about when you're, you know, as a dentist, a general dentist, dental dentists do a lot of the incision and drainage, or if you don't, refer it to someone who will. Here's a cellulitis really that comes in underneath the platysmal muscle, so this is really pushing out heavy, but if you go in here, you don't see anything. So this is an incision that probably has to be made extraorally. So this has to be done either from a surgical perspective with betadine scrubs, isolation, and so forth, or you refer it to somebody who's going to do that. Here's a buccal space abscess. We see a lot of these, by the way. We see a lot of these in relationship to first molar and second premolar abscesses. Okay. Probably in adolescence, the most common tooth that they lose or have decay in is the mandibular first molar. Okay. So this is a buccal space abscess. Okay. If you don't think tonsillitis can kill you, this is a palatine tonsil that is enlarged. Okay, if both of them were enlarged, they would close the airway. That was one of the reasons that for a long time they, you know, if they had tonsillitis more than once, they took the tonsils out. Now they don't take tonsils out as readily. Why? What do they find out about tonsils?
Or the immune system.
They help to in particular resist the entry of viral causing bacteria, of cancer causing viral bacteria, viruses, I'm sorry. They actually are. So when I was in a hospital rotation, you go in, you look at the surgery schedule, there might be like a cystoscopic evaluation, there might be some type of other surgical procedure, and then there were 10 TNAs, tonsils and adenoids. That's how the profession of otorhinolaryngology gets done. Okay, something we already talked about. Venous channels. What's the problem with venous channels in the head? What's the problem?
No valve.
No valves, okay? What do veins drain? What do they drain? Organs, tissues that were supplied by arterial blood, right? Okay? So they are receiving anything that is coming back from cells that could be infected, okay? Whether those happen to be dental, periodontal, okay? Oral pharyngeal tissues, they are draining those tissues. If there's an infection, it can be brought into those vessels and back into circulation. Remember, because there are no valves, depending upon positional type things that the patient does, gravitational forces can make that infection, that drainage, go back or go up into the cranial vault instead of down towards the heart. Either one is not a good choice, okay? Either one is not a good choice. So, vein and venous channels, we talked about the drainage pathways, external jugular, internal jugular, and then the tremendous pterygoid venous plexus that Netter drew, the infamous pterygoid venous plexus over here. If you see these in a cadaver, they're so small you don't even know what you're looking at, okay? All right, superficial venous channels, like here's the external jugular, receiving this communicating vessel here, and eventually draining into the junction of the subclavian and the internal jugular vein. Here's this vessel called the posterior tributary of the external jugular back here. These are anterior jugular veins here, so in relationship to neck infections. And then, of course, where does venous drainage start from? It starts up here. Here's a transverse sinus and a sigmoid sinus and an internal jugular vein. Here's a retropharyngeal vein. Here's a facial vein. So these come together, form a common facial and drain into the internal jugular. That's a typical drainage path. Okay? This is the first valves. These are the first valve. The valve protecting the upper extremity here, preventing backflow, and this valve here, that is a valve that would be reducing flow back to the heart at the internal jugular vein. Okay. Primarily associated with drainage from the upper extremity. And then draining down the brachiocephalic. Okay, so this drawing, you should, if you ever want to show a patient what the consequences of an infection in the head and neck is, you can show them that these veins also drain inside the skull into the cranial vault. And if it gets in there, it's tough to control, by the way. And this has to do with things like the blood-brain barrier and the relationship of what type of medications we can possibly get in here to counteract some kind of infection. That's why something like a meningitis is so deadly, okay, and hard to control, because once it's in there, it is tough to get rid of. Okay, then we've got these entities called lymphatics. What do the lymphatics do? Okay. What do lymphatics do? What's their primary role? What's their normal daily role? Remove substances from the extracellular space. The extracellular space is between the cells and the capillary beds or granules, okay? Large proteins get trapped in there, but we need the proteins to maintain our osmotic balances and sometimes our electrolyte balances. We need to bring water back in, okay? For every drop of water that we take in, okay, we have a certain amount that over that we try and get back into circulation. We don't try and keep extra water, we get rid of extra water. But the lymphatics are going to bring whatever water is caught in the extracellular space and bring that water back into circulation. Now, lymphatic tube is usually really demonstrated as vessels, but really lymphatics, they actually protrude into the extracellular spaces as like fingers, like closed-end tubes, closed-end fingers, and bring that substance back into circulation. Okay, so they're not open, they don't have a direct connection to the veins at that point, or to the capillaries, okay, at that point. They are basically doing the job of sucking this stuff out of the extracellular space. What do they have associated with them? Because we don't know what's in that extracellular space, they have lymph nodes. They have lymphatic material that reacts to foreign entities. Anything it recognizes as foreign, it will go into a phase where it starts to produce lymphocytes, and those lymphocytes hopefully can counteract whatever entity has gotten into the bloodstream. looked at this slide before. Every anatomist has a different labeling for lymph nodes, but primarily we have up here, we have these parotid and facial lymph nodes. We have submandibular lymph nodes over here. We may have a jugular-digastric lymph node over here as the posterior belly of the digastric crosses the internal jugular vein. Over here we've got superficial parotid nodes in here and deep parotid nodes, and sometimes one of the images I gave you, you can see it looks like the parotid is extended out here, but those are actually parotid lymph nodes surrounding the parotid duct. We have these deep cervical lymph nodes that are along the anterior and posterior border of the sternocleidomastoid muscle. We have some of these superficial cervical lymph nodes along the outside of the sternocleidomastoid muscle. Here they use the term anterior jugular nodes, and here they use this term superficial parietal. Lymph nodes are active. Where does lymph drain? Where does lymph drain? It's got to get back into the system. Where does it get back into the system? The junction is subclavian internal jugular by a vessel called what? Thoracic duct, primarily on the left side. But recent past, when I say recent past, 20 or 30 years ago, they discovered there's a right lymphatic duct that drains into the right brachiocephalic artery. I'm sorry, brachiocephalic vein, but it does not drain from below. Only drains from above. So the right lymphatic duct drains the right side of the head and neck. Okay. Same slide. Okay. There is a lymph node or lymphatic formation in the oral cavity, around the back of the oral cavity, that was described by a guy named Waldeier. Okay. And here we're looking into the pharynx, a little inflamed, I guess that helps. Here's the tonsil over here, palatine tonsil over here. Here is the posterior pillar that's formed by the palatopharyngeus muscle back here, okay? This pillar here, this anterior pillar to do a line on, that is formed by the palatoglossus muscle, okay? But this is the uvula hanging down the back from the palate. But up here in the nasopharynx, there's this entity that is also lymphatic tissue on the posterior pharyngeal wall of the nasopharynx, called the pharyngeal tonsil or the adenoid. Okay? So there's tonsillar tissue here, there's tonsillar tissue here, and then on the back of the tongue, there is lingual tonsillar tissue. So they describe this as Waldeier's lymphatic ring. Okay? Not a bad idea, trying to protect the body before things could get into the systemic tubular system.
Is uvula also a lymphatic?
Not much. No, uvula is not lymph node tissue. Uvula is not. But up here, above it, behind it, the adenoid tissue of the pharyngeal. Okay, and just here's another list of lymph nodes and where they drain. But this is what happens to a lymph node when it becomes engaged. Okay? Here, nothing's going on. It has these germinal centers. It has points of vascular input and output. And here it has been activated because of some type of foreign entity has entered into the lymphatic system, and now these germinal centers start to produce a huge amount of lymphocytes to try and counteract whatever it is. Okay? If it loses the battle, it can be broken down. The tissue can become granulomatous and necrotic. Okay? And a lymph node can actually become abscessed as well. Okay? Now, have they talked, did Dr. Stoyanov talk to you about lymph nodes at all? No, I'm kind of surprised.
No, we've
I haven't
been
had
covering
Yeah,
this.
that-
knowledge.
Okay, so in a lymph node that you palpate, and now, they talk about this, Dr. Pinto talk about this? You feel the lymph nodes, and if they are enlarged, okay? If they're not enlarged, they haven't been attacked by anything. Okay? That's what you're looking for. You're looking for an enlarged lymph node. If it is soft and moves around, you would expect that in something, let's say the submental lymph nodes enlarged, submandibular lymph nodes, okay? Possibly preauricular lymph nodes, occipital lymph nodes, or lymph nodes anywhere else in the body. You expect them to be enlarged, and they may be tender, but they move around. You can move them around. You can feel them and you can move them around. If a lymph node is taken over by some type of metastatic entity, the metastatic entity basically destroys the lymph node, exits the lymph node, and ties it down to the surrounding tissue. Okay? Sometimes chronic irritation of lymph nodes in some individuals can kind of fool you and cause that lymph node to get tied down to the surrounding tissues. Now this kind of creates a quandary for the clinician, because lymph nodes that have been involved in cancer, they are hard, they are fixed, and they are not painful. So if you feel a lymph node in a patient, maybe in the submandibular area or someplace else up here in the cervical area, to be honest with you, you gotta come to some conclusion, and it feels like it's not moving. You gotta look at the tissues intraorally, extraorally again, and you've gotta come to some decision whether that needs to be biopsy to determine whether this is some type of cancer, or whether it is just something that's just due to some type of chronic irritation to the lymph. But, you know, all of this stuff, we've got these, how, you know, in my day, we had to write everything down in our chart. Now you have the luxury of being able to just type it in there forever. So don't make a mistake, because it is forever, okay? And that's the thing with the electronic record. They did that. I think they did it more to try and protect patients and help attorneys than they did to help the clinician themselves. This takes a lot of time to do that data. All right. Now you've got, at least you got Friday afternoon off. And I guess Friday morning, if you can confirm that Dr. Tandler is not going to
Well,
lecture.
I'm working on it.
Right,
No
yeah, yeah.
response yet, so we'll see. I've heard he